Board of Directors meeting held this Wednesday on the 2nd of As normal, we begin with our colleague story, and we have two colleagues there.
Emma and Kim.
Emma and Kim, that's right. Can I invite you to present the colleague story, and then we'll have
So I'll just do an opening. I really want to extend a very warm welcome to Emma and Kim, their colleagues from speech and language therapy. And as I've said to them this morning, if every manager put the time and the care that they've put into looking after their team and their colleagues so they are at their best to give to our patients, we would be really, really fortunate. I think it's fantastic the work they've done, and I'll just invite you to come over and share your story with us.
Firstly, thank you for such a warm welcome and inviting us here this morning to talk about the Berry Paediatric Speech and Language Therapy. It's focused on health and wellbeing. So I'm Kim Huff.
And I'm Emma Levine.
I know you all have access to the template that we submitted, so we'll try and expand and talk a little bit more about some of the information on there. There's a little summary of who we are and our team and where you can find us. So as part of that, I work primarily in clinics supporting initial assessments and reviews, and I also jointly lead on the stammering pathway.
Yeah, and I work mostly in mainstream schools as part of a commission service. So the school buys in speech therapy for 2 days a week, and I also do 1 day hearing impairment.
So the question, why did team health and wellbeing become more of a focus for us? Well, the findings that we were getting from the staff survey and also from our high performance team culture survey, and when we were looking at our balanced scorecard, there was lots of things that we were very proud of and that was working well. It's a wonderful team that we work with. I've been there for many years, so we're doing some things right. But there was some messages coming from the survey and also during the wellbeing conversations as part of the regular monthly check-ins with staff around the demands of caseload, admin, increasing demands, working in isolation because we're dotted around in clinics. So as part of that, we knew that we needed to put more time and attention focused in the area of health and wellbeing to foster that more healthy and safe culture for our individual team members and as a team on the whole. Emma and I trained as mental health champions as part of the SCARF offer, which I think supported our confidence in navigating all the tools and resources available, which in turn helped us signpost colleagues as and when needed. We were then approached by our team leader to take on a more in-depth role, just driving forward what we wanted to do with health and wellbeing. We then linked in with the SCARF team closely, and a special mention to Sharon Lord, who worked with us to develop a more specific questionnaire to the speech and language therapy team, which we then were able to look out and pick out themes that were important to the team. So stress management, sleep, wanting more social overlap, and also there were some members unsure of what was available on SCARF and how to access that. So that, along with team discussions about what's working well, what we want to do more of, thinking about other teams and what they're doing, we had that brainstorm that informed our wellbeing support package. And I know on the template, Sharon has kindly included a summary of what that support package is all about. I'll pass on to Emma.
So since we've met with Sharon, we actually meet with her quite regularly. She offers us so much support. And we have then put in quite a few actions. So we arranged for Sharon to deliver a session to our team. We have monthly team meetings, and within those monthly team meetings now, we always have some dedicated wellbeing time. So in February, Sharon came in to deliver a session to the team on SCARF overview and talked to us about the stress scorecard. And so many members of our team didn't even know how to access SCARF from the intranet. We've created new ways to increase awareness about wellbeing throughout the working week. So Kim and I, we both send Wednesday wellbeing emails. So that's different from our team lead will send out a more generic email, which is more work-based. But on our Wednesday wellbeing, we do everyday helpful strategies, winding down to finish the working day, some mindfulness. So we try to sort out in our diaries who's going to be in charge of sending those on the Wednesdays. We've also accessed Tom Gleaves, who is the Wellbeing Coach Project Lead, and he offers a lot of bite-sized sessions. These are available to book on the intranet. And I think before we had these roles, we would send out to the team saying, these might be really useful, please book on. And everyone would say, oh, that they sound really great, but no one actually. Then everyone looked in their diary and thought, I don't know when I'm going to find time to do it. So we've actually arranged for Tom to come to one of our team meetings. He delivered Developing Your Inner Coach. Transforming your inner critic to your inner coach. And he's coming in a few months to do self-care. We also accessed Sarah Jones, who is the complementary therapy lead. So she came and did a 10 to 15 minute therapy set, like a treatment session to every member of our team who wanted. So like a massage or, she had a few different treatment offers that you could pick. We've also implemented more creative ways to connect and check in with each other. So we've set up a WhatsApp group. Had to have a few rules with our WhatsApp group because some people initially were using it as is room 1103 free. So we've had to keep it more to well-being. But now we put in about birthdays. I know that it was at the end of Eid, so people put in, because there's 2 members of our staff who celebrated that, and any like nice offers that we see on National Trust membership. So we try and keep it to purely well-being. We've also, in our monthly meetings, we share traditions. So we've got quite a lot of different religions that people celebrate. So we did a Jewish New Year one where we brought in an apple and honey. We've had 2 members of our team talk about Ramadan. Even had a few members of the team who don't fast to try and see if they can fast to see what it feels like for them. We do birthday cards as well. So we have a list of everyone's birthday. And then in the team meeting, we'll send round cards and everyone will sign and write a bit of a personal message in the cards. So in terms of feedback, we've had lots of lovely feedback from the team. It's more after we've delivered the sessions that they've said that, oh, I really enjoyed the session, good to have time out to focus on it, really helped me to stop and think about what I'm doing, good to know where the SCARF resources are. So we've had really lovely feedback and we've not had any formative data yet because we're going to redo the questionnaire, but people's general well-being and that it's all been really positive. And we also had, we've got one male speech therapist in our team and his wife came to do a crochet session during lunch at our last meeting, which was really nice. So the actions that we've put in to happen next are we're going to have a team menopause awareness session delivered by Sharon. She had a look at, we are mostly women, as they were, is it 24 of us and one of them is a man, so, and we're all approaching the age. So we thought that that would be really useful to have a teen menopause awareness session. We've got Tom coming to deliver another bite-sized session. Now that Sharon's shown us all the SCARF resources, our team particularly like the life tree. So we're going to use that as a bit of checking in to see how people are feeling, where they'd like to be, and the stress scorecard. So we're going to review the team survey, especially around the areas of wellbeing and accessing SCARF resources. And then we've decided with Sharon that we're going to come up with, agree 3 ideas for the year with the team that we want to focus on, and maybe do a charity event, because we thought that that might be nice for bonding and just to keep the momentum high. So yeah, thank you.
Can I thank both of you, Emma and Kim? That was a really impressive and very clear presentation, and I welcome the input from our speech language therapists. We don't often truly understand exactly what you do, but I never underestimate what you do. So it's very complicated, and you within a very enhanced clinical and non-clinical environment. Sometimes we can forget that. But you brought to life the changes and improvements you've made and shared with your colleagues through SCARF. It's great to know that SCARF in terms of awareness is becoming more familiar with your team, and you've been very innovative and creative in not just delivering the opportunity, but bringing in other colleagues from NCA to help and support you. And I'm really excited about what happens next. So on behalf of the board at this point, let's move on colleague stories integral to our understanding and learning from you. Not only are we impressed and inspired by what you share with us in terms of what you're doing, but also it needs to connect with your life and the thoughts that you take to look after yourself, because we can't, again, overestimate how important that is. It's crucial that staff wellbeing conversations take place, that you feel guided and supported in the process that we offer, and that you can extend those resources through how you communicate and provide all these different wonderful touch points for people to set back, pause and reflect and have time out for themselves. So unless there are any comments from the colleagues, oh, there are 2 sets. 3, that's Carmen. Bring Carmen in, thank you.
Thank you. Great to hear what you're doing. I'm the World Wellbeing Guardian, and I meet with Sharon very regularly, and she tells me about all of the meetings and the staff team meetings she goes to. It's fabulous to hear it from the other side. I know she does a marvellous job of helping people understand what's available in terms of resources. To hear about it being implemented and the impact, and to hear your passion is fabulous. If we could roll you out across NCA, it would be amazing. I don't know if the members of your team complete the quarterly pulse survey. If you could encourage them to do that, that would be on top of what we do. Then we would get some really rich data in terms of how people feel. So thank you for what you're doing. It's great to hear. You're using everything that's there, and as well as doing your job. So that's really impressive. So thank you very much.
Thank you. And Aziz.
Hi, Kim, Emma, it's really, really fantastic to hear from you. And, I kind of echo what Carmen was saying, because, we hear about I chair the people committee, by the way. So and Carmen sits on the people committee too. So we talk a lot about staff well-being, and we know, we can't do anything without our staff being well. So to hear all the things you're doing, and actually you seem to be going above and beyond. And I think a lot of the time when we talk about the policies and we know about SCARF and well-being, but to hear you say that staff don't know about it, and I know that because I've worked in organisations, and I just love the way you are really communicating with your staff, because it's not their fault they don't know these things. It's up to us to help them access the services that are there for them. And I think what you're doing is really, really important. As Carmen said, if we could do this across our organisation so the staff know the support that is there for them, that really would help us all deliver, a better working place for our staff, but a better service for our patients. So thank you from the bottom of my heart.
Thank you. So thank you, colleagues. Thank you, Kim and Emma again. I think we pick up the action through our comments. to help promote your story, but also demonstrate how effective you can be when you work together and you actually make use of the SCARF resources. There's no point in having them and not being accessed. Thank you very much for making the time in a busy day to come to the board. Thank you.
Thank you very much.
So colleagues, coming now move to the formal part of the agenda, may I welcome all of those colleagues, Councillor Daniels, members of the public who have joined us online. Rachel Jones, non-executive, also joined us online, and welcome. And a very, very warm welcome to Tim Griffiths, as Trust Secretary. I have to use a little bit of appreciation, but that's me. Similarly, for Suzanne Robinson, who joins us as the Chief Finance and Officer. So a very warm welcome to you. Thank you. Apologies received from Heather Cordell, Juliet Pierre. Who's advertising on behalf.
Think about Julie, what's first? First speech.
Are there any further apologies for note?
Miriam.
Miriam, thank you very much. In terms of declarations of interest, if there are anything to bring to my attention. Move to agenda item 5, minutes of the previous meeting held on the 5th of March. May I receive confirmation or otherwise that this is an accurate record of our meeting? Yes, agree, thank you very much indeed. Matters arising from the previous board meeting. Are there any matters arising that colleagues would like to bring to my attention? Shall I note? Can we progress?
No.
Oh, so,
Sorry, can I just say I sent apologies for the last meeting. I'm not love it.
sorry.
Not for the private, but not public.
Okay, thank you. So go back to agenda item 6. Are there any matters? Or can I progress to the next item? Right, thank you. Agenda item 7, actual tracker. Tim, which means my attention.
All outstanding actions, Chair, are either work in progress or been completed. As colleagues have comments, questions.
Yeah, anything for any points of clarification, or we content with the action tracker? As we all know, it's important to keep vigilant of the timelines and needs progress and in terms of closure of those actions. And as part of our choice framework, we'll also make give that due scrutiny. Thank you very much indeed. Agenda item 8, please. Our Chief Executive, Horizon Scandal.
Thank you, Chair. If I, again, I'm going to assume the documents read, and also we're talking about the NHS staff survey today as well, so I won't spend so much time with that. Other than to say, I think if anybody was in the session that we did last week, where we were just talking about improving together, a really, really good session about when we take staff survey in terms of next steps. But one of the things that we reflected on was that it's our highest ever response rate that we've had as an organisation at 5%. And in that discussion, we just compared where we were with similar sized organisations in terms of response rates. So, for example, our neighbours MFT, I think they were the other side of 50%. So it's good to see that we've got a response rate. And from my perspective, I would always try and work hard on getting as much response as possible. Whether the messages that we receive are good or bad or indifferent, I'd rather have that than have a really low response rate. I think everybody would say that generally, in comparison to last year, we kind of had a little bit of a tailing off. We kind of sit in the middle of things nationally. But again, if you in the Improving Together workshop, you can see that there's a moving space for the future now. So that, again, I won't dwell too much on that. Just moving on to the 3 R's work, really just to highlight that there are very important when we talk about how we move things forward in the organisation is how we do improvement and how we do breakthroughs. And the 3 R's is just an example of a tool that we use as part of our quality improvement approach. And it's something that we want to get out more broadly. And here you've got a couple of examples of things that I facilitated, but I don't take care. My hope is that we're going to have 200-300 people taking 3-hour session, because one of the things that's quite good about it is that it's very accessible. If you were on a board, you wanted to have a quick stand-up huddle about a breakthrough moment that you wanted to work through, or in a community setting, finance department, whatever. It's a very accessible way of being able to have a conversation about making a breakthrough and how you can actually make some improvement. And I would like to see that ultimately as being one of our core components of how we do our improvement work. But certainly in the financial context that we're in, being able to apply an approach like 3 hours will be very, very helpful in terms of helping people make breakthroughs and think about how we do things differently. Also, in what I would call the kind of equity, diversity, inclusion kind of part of certainly my lived reality. 2 really important pieces of work stated last week. One women's network conference. I don't want to embarrass Lorna, but she was kind of a little bit of centre stage around some of that, and she did a bit of kind of supporting that work as well. But quite an important conversation led by Karen Summer, who kind of taken the lead for and supported by people like Jess from our EDI, and a really important conversation had about where we move forward. We also have Giovanna there, who was talking about one of the freedom people experiences, how issues around misogyny, issues around sexism, and the work that still needs to be done, and really the importance about, particularly not just about allies, but particularly women in senior roles, the degree to which they can model both the right and wrong behaviours, and also highlighting the point that sometimes people have a perception that things like misogyny can be very much male to woman orientated, but it was talked about quite a lot that actually there is quite a bit of German misogyny, which I think, particularly for people like myself who are trying to be effective allies, just understanding the boundaries on some of it is actually quite important. We also did, or some of us were part of an anti-racism workshop, which is a little bit of a follow-up to the impacts of the riots that occurred as a result of the Southport horrible killings. It'd be fair to say we have 3 colleagues at Fairfield who were describing their lived experience, particularly a black colleague. I think there were a couple of moments where I think more people in the room were deeply upset by some of the things that were being described and what the lived experience of people were here. So if anybody was in any doubt about the work that we still need to do, just being in that session would have given some real call for pause. I will say, and I know we'll be talking about the clinical treatment model a bit later on, but I'm quite encouraged that when you look at one of the aspects of the clinical leadership model is that you ask for people's expressions of interest around leadership development and their interest in that. And I've been really, really pleased to see that the Black Asian minority ethnic dimension of that is very, very writ large. And so we need to make sure that what that needs to define of is that regardless of what maybe some of the real difficult experiences are for people, they give you a sense that maybe there are some people now who feel that they can trust us to help to develop them as leaders, and I think that's really important in the clinical context. But again, I'll revert back to that when we discuss that as a part of the agenda. A few other things on there, trust provider collaborative workshop, quite important, and bits of work, and again, for people who are not aware, there are a number of bodies that say I think always can sit on the trust provider collaborative as a chief executive representative. I also represent all of the clinical trusts in Greater Manchester and a partner on the Integrated Care Board. I'm also a board member of helping the kind of Healthy Innovation Manchester work. This particular element talks to the TPP. The reason why I just share that breadth one of the common things that sits right is the issue of money. And is very much a core part of our conversation, and certainly the TPP conversation. It was really an important dialogue, and many colleagues and in their organisation were wrestling with what we were wrestling with as a board about how do you land on something that you feel reasonably comfortable about in terms of the operational plan. So again, just to give flavour of what that is. For our standard of care, again, we'll talk about that a little bit later. I'm sure as part of the integrated performance report. Hopefully, GM as a whole kind of got to where it needed to get to. I think the ambition was to see if we could get to certainly GM as a whole to get 70% for understand where we've landed on some of that. A little bit later in our contribution to that going forward. So again, don't want to do any stealing of thunder, and I'm conscious of time, so I will just talk a little bit about probably my item on there, which is about the future of the NHS, particularly the meeting that I intended to chair on the 13th of March. But I also circulated last night for colleagues. A bit of the guys, a bit unusual. I wouldn't normally circulate what I would call a technical kind of narrative like that, but I just thought there was some really key themes that really give us a sense about direction of travel and where this is going. And one colleague who said in responding was it feels like monitor as monitor used to be. I've reflected on that in my initial response, indeed, but then I've reflected a little bit more, and I think this is something else actually. This is something deeper, and I think even though I've just given an example of other bodies that I'm part of, because we've been very much driven into a collaborative space, I think one of the messages that's certainly coming from the feedback directly is a sense of wanting people to spend more time in their organisations and some really work in that space, which is kind of sort of counterintuitive to what has been described certainly in the last 5 years or so. So I think there's just a sense of people understanding that we are in a different space, and particularly in that communication I said around last night. There's narrative there, for example, about safeguarding and effective election control. I would argue would not have been in a national set of guidance in 2 years ago, never mind 10 years ago. So I think that it's something that we do need to understand the way that the wind is facing and how we adapt as a board.
That's really good. And just demonstrate I do read things that we put into the email. That was a very important article. They've got to be actually a different rule. There is a sense of monitor for those of us who've been longer here, but there's something more about how we within the system as partners and maintain collaboration. There's a lot of focus on boards being more accountable, more focused on safeguarding the patient safety, quality of care, making sure that we own the improvements that we put into place and we sustain them, and demonstrating that accountability in how we have conversations at board and how this as a management of progress. And I think the way in which the reporting will go will be progressed will be directly with that focus in mind. So I think it is a good change coming. He also mentioned that Penny National and Northern are going to be the architects of the integration of the Department of Health and Social Care and also NHS. So that's very interesting. I have some other points I want to make, but I'm not going to. I'm going to open up comments to colleagues. Are there any questions or comments? Headlines like that, I'm sure that's really important. So, if there's any, there isn't one other comment I would like to make about the triangulation. I absolutely acknowledge how much time staff have taken to respond to the surveys. It's great that's happened, and we need to include development, approval, and enhancement. But it's important because when you triangulate what we hear from our colleagues with what we hear from our patients and then what we hear from our public, there's something in there which becomes themes. And it's through these that we can then embed improvements, identify areas of which require attention and focus, making sure we're checking the temperature, how our colleagues feel in the organisation, and also ensuring that through that lens we emphasise and enhance the patient experience and improve quality outcomes. So all of these things are actually triangulated. So very important that all of those aspects that I've mentioned are continue to be encouraged on potential stakeholders to make sure we keep pace and informed about what we need to do. And sitting in this board meetings, making decisions are making, but having line of sight of what we are telling us. It's really positive. So thank you for that. Okay. We move then into agenda item number 9, which is the integrated performance report. Judy's going to present an update on that. We recognise, don't we, colleagues, that actually many of the matters that are going to be presented in the report come articulated in the subcommittees which are delegated from the Quality Performance Committee, Example Research and Innovation, and People and Education Committee. Just bear that in mind. Thank you, Judy.
Yeah, thank you. So I think important that we look at this in the context of the AAAs from the committees to ensure that the right conversations are being had, and that actually what we see in front of us correlates with the BAF risks that are articulated, and I guess the question of whether they're being managed. I'll pull a few things out. I'll leave finance because I think Suzanne's got the more detailed finance report. But if I go to performance, then I'm going to give some of these metrics, our February and January metrics. So I'll give the most current position yet to all still be validated. That gets us to where we recommend position for performance. So if I start with cancer, because I think this is really good news for our populations. Our provisional FDS performance is 77.8. That was against the stated annual plan objective of 77%. I think that is remarkable given a 25% increase in referrals in dermatology in particular in year. There was a nominal risk as we stepped into the year. Our GP 62-day plus backlog, we set ourselves a target of 264 to reduce that backlog. Internally, we set ourselves a stretch target of trying to get to 175, and we look like we'll come in at 137. That is the lowest backlog that we have had of 63 days plus since pre-COVID. So phenomenal. And again, I say that is against a backdrop of really increasing cancer demand for this year. Because we've eaten into that backlog probably at a faster rate than we had anticipated, our 62-day performance has deteriorated slightly in months. So we've set ourselves a plan of 70%. Provisionally, it looks like about 68.6, but it can shift a little bit because of the inter-provider transfers and really finalising all that. We won't know exactly that for another month. So yeah. On urgent care, our 12-hour performance remains static, and it is something from a quality perspective we absolutely have to focus on in terms of people receiving care and the delay-related harm that's associated with it in our EDs. So we continue to focus on the same-day emergency care model in Salford and the UPC and bed shortfalls in Oldham, try to get some resolution of those. I don't think that will be a quick win, but you know, as we step into this new year, I think we're going to pay attention to are we moving those things, because it is a big stretch for us to get to where we need to be on that 4-hour commitment. We will likely, on the back of the March sprint, exit the month short of where we thought we would be. We had a plan that said 78%. We thought we could see a way to get into 72, and we discussed that in our provider oversight meetings. I don't think we'll get there. We had a really challenging March, actually, for any number of reasons, but we may get to 69%. We've still got the type 3 activity to be validated into that. However, that will still be an improvement of a couple of percent on our February position and an improvement on our March 24 position. So, you know, the numbers are going in the right direction, probably just not at the speed that we would want them to. For RTT, you can see 52 weeks looks a bit stuck, but we're stepping into this new year with some renewed actions and energy, particular focus on neurology, which is a big driver of that 52-week position. And Lorna and I are in discussions with the team about digital triage, and I think if we can make that change in here, it will take some months for it to flow through to the 52-week position, but we should see some benefits. On 65-week wages, again, numbers still to be finalised for the year. You know, we've been a bit stuck in the 40s. I think we might find a way of getting into mid-30s, but not quite real, but a slight improvement position on where we were last month. I will pick up some of the productivity issues later on this afternoon when we talk about the plan. 6-week diagnostics, I think we'll miss that 95% target that we set ourselves. We step into this year with the same target, but all 13 modalities have improved since January 24. So again, I think that's a real positive. The February position, this is the January position, it just looks like it's about 3% improved on the January position. And echo and endoscopy remain the key drivers of the gap between where we are and where we want to be. On our people metrics, I think, you know, as we step into this year, we have to be really focused on the mandatory training and my time conversations, I think, and ensuring that we get to where we want to be. You know, when we hear this morning about people being happy and healthy in work and being able to contribute meaningfully, they are two things I think that keep us safe as we manage risk into 25, 26. And we've had a number of conversations about that sickness absence and the need for us to improve that, not least to help manage our financial position, but also the quality of the care deliver for our patients. On quality, you will see that there is just a lot of natural cause variation in that. I think pressure ulcers is one for us just to be mindful of. We almost breached the control total limit a couple of times in this year, so something for us to watch. And the only thing I would want to say is the past couple of months we've had a series of infection outbreaks, be that they were just really testing it this morning. So I think while we can see some infection prevention and control data here, we just need to be mindful of outbreaks and how outbreaks are managed and what we're learning from outbreaks, because it does hinder not only the quality of care that we deliver to patients that are already poorly, but we often can have beds closed as a result of it to manage the outbreaks. And that, when we're in an Oldham situation, can really be the difference between tipping the day for us. So those would be my additional thoughts to the scorecard.
Thank you very much, Jude. Are there any comments or questions? Tim?
Yeah, I mean, thanks, Jude. I mean, that was it's really clear in kind of what we've achieved and the challenges that are underlying. On the general point, I mean, I do find that the new reports that we've had for a few months really, really helpful. I suppose just one area I would suggest is the areas of concern. They kind of disappear in the next month. I think this point of the board tracking those would be, I think, a good discipline. I mean, one of them is on the safety watch. I think around dermatology. Last month, the whole cluster of safety incidents, and we're going to address that. They kind of disappear this month. So it's probably just that discipline I think they're really clear reports, far better than we had in the past. But that would kind of keep us on track with regard to what's been done last month, and that's been close. So, thank you.
Thank you, Tim. Sue?
Sorry if I've missed this in previous boards, but the DNA rate reduction is really, really good. And I just wonder, is there a particular issue driving that, or was it a whole load of different actions?
So it's still not where we need to be. We need to be better than that. There were a couple of big actions that were taken in years. Well, a couple of things. One is the validation work we've done, and 21-day letters which we sent to patients to say, do you still need your appointment? And I think that helps you to ensure that you've got patients who've not got better while they've been waiting on the waiting list. So that's had an impact. The second is the work that we've done digitally around digital invitations. So using the doctor-doctor technology through the app to remind people of their appointment. So digital, it doesn't necessarily reach all of our populations given the deprivation, but it certainly helps. And then we've done some work specifically in our health inequality space around analysis of the patients who are most likely to DNA, and that way we can target some of those with our communications. But we've got more to do this year, definitely. You will see nationally that the organisations who serve the most deprived populations always have much higher DNA rates than those who don't. So it is a big driver in understanding that deprivation and engaging with those populations.
It's good to see that we've made an impact on it. Hopefully there'll be another big drop then.
Yeah, we need to do some more this year.
And that's also an interesting one. So we're illustrating how we see health equity lens. It's just that certification, and that's going to yield benefits. And
I'm sure this is to you, Jude, or perhaps the PALS response rate. I noticed it last month and I did raise it, as we were discussing lots of other things. We've got appears that we've got a regular failure to meet the SLA. I can see that we've got really good responses and positive feedback from the family test. In the PALS area, which I guess is working at a really unacceptable experience, and therefore they've raised a complaint. We haven't met the SLA for a very long time. I don't know whether that is related to we're under-resourced in that area. Or if we measured it on dealing with complaints within 6 days or 7 days rather than 5, we would actually meet the target, or we are just way out. And I'd like some information following the meeting report. How are we performing there, and what's the underlying issue?
I can take that, thank you. We had that discussion yesterday at our patient experience group, and exactly that same conversation. We're not in the place we need to be, and it's tracking in the wrong place. So we just asked for a deep dive from each of the care orgs at the moment. We do hear some reasons for that in relation to staffing and the increase in volume as well coming through, but that's obviously not an acceptable response. So we need to understand that a little bit more. So we're going to have a focus on that area. If there's an issue around needing to share resources, we need to do some of that as well. But absolutely not where we want it to be, and will be an area of focus with a clear expectation of where we need to get to, because these targets are very reasonable targets. We wouldn't want to do anything with them, and we did remind people of our statutory responsibilities in responding to PALS and complaints as well. So we can put more narrative onto that when we feed back next time, and it is definitely one to be watching.
Thank you. Is the 80% target we've set, or are we obliged to have that 80%?
I think that's the one that we should. I can't remember because I'm just due back in. Yeah. I think they're the ones we should be set. These seem to be reasonable targets. then we are set targets, obviously by the PHSO. That's the conversation we had. So no, we wouldn't shift those.
That can come back in the overview.
Yeah.
Thank you.
Yeah.
Appreciate it.
Katie, please.
Thank you. Sorry, I just thought it might be helpful just to pull out on the follow-up on Jude's commentary around sickness. And I suppose I thought I would get a question since I haven't. I'll add to it. I mean, sickness we can't deny is not in the space we need it to be. And as we saw on the staff survey this morning, there's a real need for us to focus on the well-being of our colleagues. But I think for board and for the public, it's just probably worth tracking through some of the areas in terms of the focus on it. So SMT is a key monthly meeting where I particularly follow through with care organisations, particularly around the correlation between their sickness absence rates and the return to works, because we know how important a timely welcome back conversation is. It's something that we've also tracked through the People and Education Committee, of which Aziz is chair and follows up with all of the care organisations. Juliet's just leading a piece of work this year around really focusing on our nursing and healthcare support workers, which, as we know, is our biggest staff groups, and real focus on that. And the people and HR teams will be doing some really good skills development with managers, because obviously there is some discussion around, is it a policy issue? Is it skills issue? And I think it's more around giving people the focus and the confidence. And as you know, Aziz picked up after the colleague story this morning, it's about making sure people know there's great services there to help and support them, whether it's financial wellbeing, physical wellbeing, or mental wellbeing. We've also changed and updated our reporting going into the People and Education Committee so that non-executive colleagues have a clear sight of not just sickness absence rates, but the care organisations welcome back rates, because we can see a direct correlation in high sickness and low return to work rates. So it's just to give colleagues that assurance around connectivity across all areas, which I thought might help. Thank you, Chair.
Thank you for doing this as well. Can we move to Rachel? Sure.
Thank you, and morning all. Could you help me understand the urgent care 4-hour standard? There's reference here to the national target having been adjusted. Could you let me know how much it's been adjusted by? And also, I guess, this stands out for me as perhaps an area that we've seen quite a bit below target. I know this is a tricky one, but can you talk a little bit about that? A little bit about that for us, please. The second one is around the ambulance handover. This one obviously has a huge correlation to demand, but we've got quite a significant dip in January. And again, one that happened back in October 23 as well. Do we know what drives that dip? And are there any sort of initiatives we could be looking at to avoid that in the future? Thanks, Jude.
Yeah, thanks, Rachel. So the national target hasn't changed. It's at 78%. But I think through our provider oversight meetings, we had outlined that early on, I think, that we couldn't see a way to get to the 78%. And we know some of the reasons for that, the strategic bed modelling at Oldham, some of the space issues that we have got. So we had committed that we thought with the improvement actions we had, we could see a way to 72%. I think we will fall short of that. And some of the reasons are, I think as I've described, we need a better functioning SDEC model across Salford as a priority to be able to pull out of the emergency department. And all of these things flow back to ambulance delays, actually. The minute your emergency department is overcrowded, your ability to offload safely becomes compromised. So the priorities in Salford are the functioning SDEC model. We can see in the GIRFT metrics that actually some of our measures on frailty, length of stay for frailty, how we handle frailty, are really good, and they benchmark really well nationally. But we still do have some very long lengths of stay that we are required to focus on. The other issues sit at Oldham, which are the need to expand the footprint of the ED to get really effective flow and to think about a resolution to the bed modelling. So I think I'm really confident, and NHS and GIRFT in their visits to us as part of our urgent care improvement have confirmed that the improvement actions that we have in our plans are the right ones. There are barriers to the easy delivery of some of those solutions, and some of that is the money, you know, about how do we recycle some of the monies we've had. You know, we've closed the beds and we've sipped that money this year. We had a bit of a conversation at SIP meeting this week about what's in our line of sight for potential bed closures this year, and do we need to think about how do we recycle that to support Oldham? So I do think 78% is going to be a challenge, but I am confident that our improvement plans are correct. I think we need more clinical leadership, I would say, in this space in some areas, particularly in Salford. I think, you know, we still have an outstanding CQC rating of inadequate for safety in that department. So Salford has got to be a priority area for improvement. We also know that Rochdale's struggled a little bit actually in this last quarter. So if you compare all of our sites like for like compared to last year and last month, Bury's held its own. Actually, Rochdale and Oldham have improved slightly, but Rochdale's deteriorated, and some of that is the acuity. And if you remember, we rolled out a new NHS acuity tool, and that has given us really valuable data to say that the patients that are turning up in the UTC at Rochdale are as acute as some of those that are turning up in the type 1 EDs. And you know, we don't have a similar kind of model for medical cover and nursing cover because it is at the end of the day UTC. On the ambulance handovers, we'll change this metric next year because really the target that we are measured by regionally is 30 minutes, not 15. And we are just outside the 30-minute handovers. And the reason why we get spikes and deterioration in handovers is largely driven by two things. One, we've not got flow out of the department, and so the department becomes snared up, and we have a limit to how many patients we will offload onto corridors for fire safety reasons, if nothing else. And the second issue is surges. So if I tell you on Monday, we had 5 ambulances all turned up within 12 minutes of one another at Oldham in Monday afternoon in a busy department. So those surges of ambulance arrivals sometimes are the things that tip us. Does that help, Rachel?
Definitely, lots of detail there. Thanks, Jude. I think that urgent care 4-hour standard definitely stands out for me each board meeting. And I think looking at that graphic, it looks like historically we haven't come close to that 78. So it definitely feels like an area of where we probably need more clarity about that path to target. And as you say, at the minute, we're not confident we have one right to target. Close perhaps, but not target. Maybe something we could look at future board, Jude, in slightly more detail, or a board learning session, please. You know, perhaps the focus on it could help get some of that clinical focus that you've referred to. Thank you.
Thanks, Jo.
I had a really good input at the start of this meeting on speech and language services. Still don't get any information on these reports about performance on community health services. I know we talked about this in the past. Is there an update on the work to close that gap?
Yes, thanks, Jeff. So we will be looking to see what we can put in here when we talk about the annual plan objectives in part 2. I think there's a gap in an objective this year, but the neighbourhood model should add that in. The issue for us is the reliability of the data, and the Honest team are working really hard because whatever we pull through into the scorecard, we need to have some confidence that it's not pen and paper around. We're really scrabbling around at the end of the month to try to put the data through, which is where we've been. But Lorna's team have done quite a bit of work with the community board. So I'll bring some proposals probably through to Quality and Performance Committee about what are the key things that we want to track. We do look at children and young people's waiting times in performance and planning. And we do report that up through Q&A because it's just been focus for us. And again, I've highlighted that in next year's objectives about waiting times for children with young people's speech and language, because I think that's a part of school readiness for us and ensuring that population in the future is our contribution to what is delivered. So let me discuss with teams about what we can reliably pull through into the scorecard for next year.
And so really important for this race of council presentations, so they're in alignment. There's also something, isn't there, colleagues, about how we understand performance in context. So there's something, there's an immediacy about it, and some of the actions intended to go through that in response to questions. Suggest we're being sometimes reactive because we don't know what's going to come through the front door. Sometimes proactive, but we need to be longer term planning. We need to look much more beyond the intervention that we put in place. It's sustainable and understand their impact. We're not going to resolve urgent care, which is why it is a priority for us, but there is an elevated focus, isn't there? Because there's a feeling generally by the NHS that perhaps we can maintain improvements in those areas, but we have to look at this globally. And the IPR tells us very clearly that there's still work to be done. There are some other headlines I'd like to pick up later, colleagues, which are on stillbirths during the consider the report. The IPC, Jude mentioned infection prevention control, CDIP is on address now. The other one is the emerging themes around pressures, because as a patient safety, from a patient safety perspective, we have discussed this before. I am concerned about the trend going in one direction. We just need to harness that. Very clear what's happening within that area. That's it for now. So colleagues will move then to the next agenda item, which is 10. And it's Sue. You're going to present. Thank you.
Chair.
I think it's him. We're being a tin chair the last committee meeting.
Sue's away.
Just to confirm the meeting stood down. Do actually.
Yeah, that's great. That's confused me.
Excuse me as well.
Yeah, I reported last board on the finance committee.
The meeting stood down, so just going to make it clear. Okay, so we now move to matters reservation, which is with Susan. That was the initiation bit.
And so I will hear the report of spread for 11, just to bring the school to date in terms of where things are now. We are on trajectory to deliver our full year revenue plan and towards a deficit, which will be a huge achievement given the challenges this year. And within that, delivery of the cost improvement, not only in form but beyond what we set out to achieve at 89. Just a couple of highlights, if I may, as well. Just in terms of capital, I know that's been an area of focus within the board and within the finance committee. And having spoken with Tom McManus last night, I can confirm that we have delivered the capital plan in full at 63.9. It was a real stretch and challenge to achieve that. So again, a positive outcome. I'll just finish on our position, just touching on cash, incredibly important area, and what I would assess as a reasonably healthy cash position from a liquidity perspective, compared to others, but something that will need to be a real focus for us going into 2026. earlier in the meeting will help us thinking about facility cash and how we as a board effectively manage that into next year. And then the last comment I would make is just in the context of Greater Manchester. So our ICB yesterday that they have now locked down the payment of the year-end position with NHS England to deliver £69 million variance to our green control tower, all of which ourselves would have business ICB contribute to.
Thank you very much indeed, Susan. Your question. And we acknowledge, and I think you acknowledge Ray Carter actually the amazing work he's done, particularly to come on time who were adapting. Thank you. Are there any comments or questions? Sue?
So for Suzanne or Joe, I know it's only day 2 for you. One of the ways of hitting our plan for 25-26 was to make sure that we hit our recurrent CIP target for 24-25, and I understand there was some work going on around trying to switch the non-recurrent SIPs into recurrent SIPs so that they didn't come forward as a pressure into the current year's plan. Did we manage to do that?
Jen? Yes, I did check on that, Sue. It's obviously one of the things that I was keen to understand in terms of setting ourselves the most solid of platforms into next year was doing that from as you described. We did achieve the 61.
Well done.
Which is again a huge achievement.
Any further questions or comments? No?
Yeah, I just think it's just worth pointing out that when we come on to the thought process for 25-26, we've currently still got the same expectation, sort of 75-25 split. So that would mean 82.5 million against 10 million for the year that we're in. What we've seen across GM has been probably a shift in the recurrent, non-recurrent. So one trust I can think of was kind of moving from the sort of 75-25 that we were in to a kind of a 30-70. So that's 30 recurring, 70 non-recurring. Obviously, if you take that direction of travel, you are adding to your underlying deficit position around that. But there is maybe a sort of tactical view or a perspective that people are taking that says, given the severity of cost improvement planning for the year that we're now in, that kind of standing still might be a good tactical thing to think about. So we just might need to have a conversation about our current 75-25 ambition and just a road test. Is that something that we'll want to think about moving forward? So I just put that the opportunity just to add that into the conversation. Thank you, Chair.
That's really good. I think right up the coming down the head and was quick driving it. Soon your light is still on. Are you coming back or are you Jeff?
I thought to the Finance Committee.
Oh, you got your light.
I'm sorry.
So, okay, so
Chair, there's maybe literally what pick up these finance committee, but on the question of current versus non-current, because I don't understand the tactical advantage of not getting as much recurrent as you can. So the education about NHS processes. But coming back to the achievement of this year, turning a substantial amount of non-currency into recurrent in a matter of weeks. Again, I really have to understand how we did that, because there's always a risk that you call something recurrent. It's not really, and it comes back to the balance sheet as overspending in the following year. So again, I want to discuss detail with that. There's some of the issues that are very on this particular issue.
it's not that.
Yeah, I've seen this problem. So there were a number of schemes where, and particularly related to vacancy control factors, where we would normally adopt a kind of a non-recurrent approach to that. And what we've done in consultation with the care organisations themselves is we've taken a decision with them that says that actually we're going to do the budget removal around some of this, which is what makes that recurrent. That's how we bridge that gap. Now, there's all the, Suzanne will talk more about this with data control, fact, you've got to be really careful about that, because lo and behold, then there becomes service demands next year that sort of like says, but the kind of attitude that we've had on this, and we're going to take some of this into next year, or the year in, sorry, is that we kind of had that, if you've had vacancies, you've got an establishment, you've never really filled that establishment, and you just cycle year in, and there's always that gap. Kind of how we bridge the gap this year, and you say, well, actually, we've got a pattern, we're going to take the risk that says you never close that gap to establishment, so now we're going to, in effect, to create a new establishment, and work through, as I say, we have to QIA and EQIA that consistently, because that's quite a significant change. And I think, Jeff, big part of what I'm saying is, okay, that might be good now, but if it springs back next year, then that's problematic. That's what we're going to keep an eye on. And that's why, again, I think the debate for us about, what proportion we have ambition-wise for recurring, non-recurring this year has to take those factors into account, that we have done something unique in the year we've just left to bridge to get to that 64.2 million against the 85.6 that we were on. So I need to tell you that there's precise answers around some of this, but we are working it through. And I think it's about the judgment the board's going to have to make about its risk appetite generally.
And it's exactly the right question to ask, because we need to be clear about the information we're using to inform our decisions, and action we then take is good clarification with them. Thank you, Jeff. Colleagues, can I move to recommendation? The board has to receive the monthly finance position updates, please. Really, thank you. Policy and performance, agenda item 11. Chris.
Thanks, Chair. So this is the report of the meeting on when was it? 17th of March. And I'll just put the usual caveats on this. Clearly, in the report here, you can only cover a sort of selection of the items that we discussed. The minutes which are available cover the sort of detail of it. So just make that point. But you do see in the report the range of items that we considered. Because my colleagues who are on the committee, we do our 3-hour sprint, don't we? Or 3-hour boom through them.
4 hours reading.
A long list of issues. And I think we do manage to give appropriate scrutiny, but there is a large volume of things there that we look at. So thanks to everybody who participated who input. A number of the things that we discussed at the committee have already been discussed at the board. So, for example, the performance evaluation that Jude's talked about, and so on. In terms of alerts, I'm trying to draw out just 2 themes really, rather than specific issues, but themes. The first one, second that's important to put it, is that several of the reports that we got seem to be identifying to us the sort of real life clinical individual person consequences of some of the pressures that people in their reports. So things like sepsis management, care of the deteriorating patient, the fractured neck of femur pathway, which is being looked at. These are things which, because of the pressures, can be difficulties with those issues. And I think it was assuring to hear of the way that those things have been identified and were being tackled, particularly the neck of femur, the broken hip pathway and so on, where it had been identified through an alert something being done to address that. So I try to do it, and that comes up in the Learning from Deaths paper later. I put it here, I think, really just to make that point, but also suggest that maybe this is the sort of thing that we might hear about at a future meeting, because it really brings to life the actual impact of some of these waiting times and some of the. If it was possible to have a member of staff talking about the pathway or even patients, I think that would really bring to life some of the issues we talk about in spiritual. The other alert here is on the what I call learning organisation. We talked about in previous reports, but I have to say it's really quite a theme in the reports which coming to Quality Performance Committee, where we were finding that there were learning points from previous investigations or whatever, which were outstanding that we were trying to follow up. So, and the execs who were at the meeting agreed that they would really go away and have a concentrated look at those issues and try to make sure they're closed off. I think really demonstrating, there's an opportunity to really demonstrate that we're learning from those issues. So, Chairman pointed out that's something there has been a really welcome reduction in the number of outstanding internal audit actions. Got more to do. So that's the point there. Under advise, and so that the assurance in that one is that the executives were going to have a good look at those issues and come back to the report at the next meeting. Under advise, performance and planning talked about spinal services is on the agenda for today, so I'm not going to go through that. What I would say there, though, is that we, as the Quality Performance Committee, are wanting to really sort of move on now to thinking about the current situation within our spinal services. Like Rafiq will talk about the work that's been done in response to the report, but we're sort of now seeking information about how the current state for our patients. So that issue. On the Assure section, yes, we have noted in previous reports that the steps that have been taken to really get a quality governance system in place. I think we'd all recognise that we're not there yet, and through the help of Juliet and Tim, there's a process at the moment going on to really have a good look at that process, those subcommittee structures, and get them in their optimal function. They're not there yet. I think we just need to acknowledge that and make that clear. I did want to make the point about quality improvement. I thought this was a very important and interesting fact that was hidden away in a report, really, around the training for quality improvement, to the quality improvement training which goes on at the sort of level 1, level 2 competency. And I did think that was something that we could draw out more, because it's the other side of the sort of governance stuff, isn't it? It's the improvement stuff. So a bit of assurance on that. On assurance also, just so that the board is aware that the quality performance did receive a report on the debt and had a good look at that, thanks to the Rafiq team. And that report and the maternity report that they talk about are two things which, whilst we do scrutinise in some detail at the maternity committee, at the Quality Performance Committee, and indeed maternity issues are looked at in the elsewhere as well. They are two things where there is a mandated reporting process for the board as well. So whilst I would want to make the point that we have looked at these, they have been scrutinised, that it is also important that they come to the board for the board to see. In the case of learning from deaths, there's a sort of data set, isn't there, Rafiq, that is required to be reported. And in terms of maternity, the perinatal statistics are required to be reported directly to the board. You see, under board assurance framework, we looked at the 3 risks assigned to the committee, and I'd say it's quite some discussion on the quality systems. I think we decided on balance that it should remain at 16, pending further information of the work that's being done to improve it. The risk for capacity and demand, certainly in terms of planned care, I think based on the sort of outstanding information which is has been reduced. I mean, I could possibly reduce further. It is reduced actually, but unplanned care remained at a high risk for the reasons said, and maternity again, in view of the data that's been produced, assurance that BAF risk could be reduced further. Learning, I think there is something about how we take the outcome of reviews and audits and feed it into the system, and then just to make sure the board is aware that the one thing that we approved under our delegated responsibility was the annual radiation protection assurance statement. There are 2 reports, Chair, which follow: perinatal quality surveillance report and the learning from death report. As I said, I'll just say it again to emphasise that we look at these, but it is important they are seen by the whole board.
Thank you, Chris. That's a really comprehensive update and details on the right places. And again, the subcommittees on particularly around assurance. I have a question on a basket around maternity, so I'll come back to later. I'm going to invite colleagues to see whether they're competent in clarification. Repeat, please.
Thank you, Chair, and thank you, Chris. I think there's a lot of really good work that's happening in QPC to help us on the road of getting to where we need to be from a quality assurance perspective. I just wanted to say a couple of things. First, to support the inclusion of the clinical impact of some of our processes, etc. I think this is really helpful, and it actually connects with a couple of things that will come up in the perinatal report, and it's handy for us collectively as a board to be seeing these things and in context of financial issues that we have. I think it's also as with Chris, there's a couple of things that will come up in later papers, so I won't dwell on them here. But it's fair to say that more work needs to be done, certainly from a clinical audit perspective, some assurance there. And there's a mention in there as well of the gastric tubes specifically, which board will recall have been an area of concern for us as an organisation for some time. One of the things we've now found is that there's a little bit of a gap between what has actually happened versus the appropriate assurance and reporting and requirements that's captured by audit. So that gap we're acting on in terms of ensuring we've reached it, and we have reporting that is fully reflective of where we are, so we can move forward with that. So I think that's just important to recognize. Thank you.
Thank you. Julie.
Thank you, Chair. I'm just going to build a little bit on what Chris said about the piece of work we're doing around governance. So we're as a response to the meeting, the last QPC, we've agreed to have the next meeting as an executive-only meeting, acknowledging there's some business that we just need to get on top of in relation to closing down actions, which that would be better doing it, and we're going to try out a different way of kind of managing the reports as well. This is all, we're working very closely with Chris on this. We expect to get to a place we need to within the next 8 to 12 weeks. We've got one of our senior managers working on this, as well as QPC and as Rafiq said, the groups that are feeding into QPC, with the intention that we get this clear line of sight from board to ward, which I don't think we've had on all of the areas that we need to. You can clearly see in some, as we can see with maternity, but some of those areas we're not exactly seeing that. So that's the output that we're intending to achieve by this piece of work. And then at a point in time, we'll get the right level of independent assurance on the processes that we've got set up. So that'll all be within this calendar year. But it's a kind of a piece of improvement on quality assurance.
Thank you very much. I think it's really important to maintain the focus in that area. These are outstanding high risk infections, which are through visual, NGT, national relocation, and also around consent. Very important areas and amongst others. So can you give a more specific timeline about when we can expect to see how the recovery plan will be put in place to address those? Just because.
I mean, I can certainly bring an update to the next board meeting. I think
just
we can keep bringing the progress on that. Obviously, we're working with Chris very carefully on that. But
thank you. And also an update on my next patients as well, because that's kind of also outstanding. Just pause there, Rachel. And Chris, are you coming back? You're actually trying to see.
Sorry.
It's fine. Rachel,
Thank you, Chair. Just a point around wording, really. On page 4 or 5 of the update report, I was wondering if we could change some wording on this one. So the reference to the increase, albeit not significant, either add some punctuation in there, or if we could remove the word significant, please, and put it to material. It's just that line, if read by somebody who had a neonatal death, could be read as being a little insensitively worded. So if we could just adjust that, please, I'd appreciate that. That was the only point. Thanks, Chair.
thank you, Chair.
That's me. I'll take that on board. Thank you, Rachel.
So my final question or point of clarification on this one is reducing the risk score in maternity. That I know that we have made very important improvements, but then we have sickness absence within maternity, which can impact patient safety, can impact our establishment. I just want you to factor that into the review if they don't take forward. But also we've had again stillbirth increases, which is very unfortunate, but we need to be mindful that our focus in terms of reviewing the risk score on maternity considers those matters. I understand in which context you made them, but we have reduced the risk score. Reviewing is about continuing with what we have, but we're also increasing based on what we know.
Yeah, I think it's the I'm just saying still look red sort of remained.
It wasn't statistically significant. There was one, wasn't it?
And I think because the numbers are so small as well, you can see quite significant swings, but over a period of time it has been consistently reducing. But that's not to say that we shouldn't continue to monitor it extremely closely.
I think Ravina, quite right that what you pointed to is the level of risk appetite on this has got to be too high or low, but we've got to be quite cautious about making changes there. We've got to be able to see sustained improvements over a period of time to be confident about achieving those risks. So yes, I think we take this.
Tim, do you think we can?
Yeah, I think we discussed the level of mitigation we've got in place for the risks that the maternity services are high risk services, and we've got assurance on the mitigation of those risks, and that's I think where we felt confident in reducing that BAF risk because of that, and we've got really good oversight as well. So they were the factors that we considered. Got really in-depth monitoring and that sickness absence and the vacancy in maternity had got to a level where the service is able to safely manage that. But we'll keep it. It's obviously something that's been tracked at the board every month. So we wouldn't. We'd be clear about making any recommendations where we felt that risk mitigation wasn't being achieved.
You know, understand.
Yeah.
Just for I suppose it's, as Chris just said, it's about making sure we go back and review and ensure that's our responsibility and all needs as it is for the need to choose them. Tim.
Yeah, it's just that pathway to making that decision, because as you can see here, it's saying this needs to go to the improvement board. I took it to the improvement board, so it's a place that are all now shut down. So it does need to come here. I would suggest there's a follow-up niche room, isn't it? But probably in the back of that. Clearly, the improvement work. Let's save it for when we kind of need that pathway to here to make that decision, because at the moment it's going around the surface.
Thank you.
We also need the sense dealt with that it's the board, it's these subcommittees which get the final say. But you know, sort of that's where the challenge needs to come when the decision is made. I was with Tim that I'm quite wording this in the can't wanted to have to pull that out, but I felt a bit uncomfortable that we were saying it was getting somewhere else. But you know, actually, I feel that it's good or audit or people education. You know, these are the questions that should have.
Yeah, I agree. So good point made at the beginning on focus, accountability, not just at board, there's handling of committees of just to do that. And thank you very much for that. Can I suggest we have a break here? Oh, sorry.
Could I just maybe come back and do a quick my apologies, thank you. So just on the risk score, with the current sort of reshaped governance under the GPC, we have the risk management, which is chaired on Chief Nurse. And so I just want to support what Chris has just said. If we go there for an added rinse onto GPC where
With the phrase I think is confirm, which challenge or confirm, isn't it? So it's that sort of approach that we take.
Thank you for that. So can we, colleagues, please receive the report from the reporting committee and the agenda. We have mass escalation and coordinating the nature of the report, and Faith is here to present that. Would you like the break now, or should we continue to cover this report and also the learning from debts? Fine. What's the double check? Okay, I'm very good. Faith, please.
Thanks, Chair. So take the report as read. So just some highlights of some of the conversations that I've already heard in the room from the previous discussion. You'll be pleased to hear that sickness absence in perinatal services has reduced in March. So we're hoping that we are going in a positive direction. What I will say, however, is that we are continuing to close that vacancy gap, and you'll see within the report we've had some positive recruitment that is ongoing. I think the position across Greater Manchester is also changing in terms of midwifery staffing. So many organisations are now in a position where they're over-established. So we know in September there's in the region of 120 student midwives that will be graduating from both Manchester and Salford, 30 of which are currently training at Oldham and Rochdale. Therefore, if we were to recruit our 30 student midwives, which is what we intend to do as we train them and value them, we will almost have completely closed the vacancy gap, which is a really, really positive thing for staff, but also positive for our women and families accessing the service. What we do need to be cognizant of is therefore keeping that retention piece going as well, because now we've got them, we absolutely need to retain them. So that will continue to be an area of focus. With the landscape changing, we are concerned there will be student midwives that are graduating that won't be able to obtain posts. And that's a discussion that's being had across the whole of GM. So I will obviously keep you briefed on that. In terms of wellbeing and midwives not feeling the difference really yet of the increase in our staffing in our establishment. And some of that is due to the sickness, but some of it is also due to other unavailabilities. So I've spoken before about the increase in the study leave demands for our midwifery and also our obstetric teams. So that's currently running at 5 to 6%. On a weekly basis and availability within our rosters. So if we start to add all of those things together, it does significantly increase the unavailability that isn't always covered by the 23% uplift. So it's something that we're continuing to focus on a week by week basis, particularly in light of the current financial situation. And making sure that we're communicating this back to the staff, because we don't want there to continue to be a perception that staffing's really bad and we're not doing anything about it. So those communications with the team are really, really important. In terms of oversight, you'll be aware that the Maternity Improvement Board has now closed down. And I wasn't present for the last meeting, but it's unfortunate because I was on leave, but I read through some of the transcripts and believe that, you know, praise was given to the team around the work that's been done, which is fantastic. I think the key thing that we need to work on now is maintaining oversight and that accountability and scrutiny of what's happening within our statistics. And that's why that continued engagement with the board is key, that you have got absolute oversight through QPC and board of the safety metrics within the service. And also there's the availability and possibility for early escalation. So as soon as we notice that things might be slipping off or there's an area of concern, that we've got rapid escalation through to board, and that will be done through our board safety champions, so through yourself, Tim, but also through Heather and through myself, and then obviously through the walkarounds and that engagement with the teams that all parties are currently doing. At last board, I did speak about more executive oversight and doing more walk rounds, and I have had a number of emails from individuals who wanted to come and have a walk around maternity services, and I think that is even more important now with the Maternity Improvement Board stepping down. So again, just to reiterate that, please come and have a look, please come and feel it, touch it, see what's happening, because that's what's going to help to build that triangulation of assurance within the service. We do have really good engagement with our MNVP, and Tim is now attending more and more meetings within the perinatal service, as is our MNVP. And again, those links and speaking to families and speaking to people that are attending meetings will also continue to have that oversight of the service. So again, just to kind of keep that going and keep that oversight there. I think the Maternity Improvement Board has done some fantastic work in terms of the BAF risk. I agree with everything that's been said around that sustainability and really having some rigour around that review. And what we need to make sure is that we are sustaining it. I think that is absolutely key, is that we're not closing it down and saying that's it, well done. That journey and that improvement journey absolutely continues.
Thank you, Ben. I think it's really important, first of all, to acknowledge the work of the Maternity Improvement Board. I have two independent chairs, haven't we, over the last few years. You have done outstanding work in many places, and it's been great. And I think that's reflected in the fact that we can now recruit into our service, because we were struggling, really struggling with that. Retention probably is still an issue, but you're working on that, and I'm hearing that loud and clear. Really delighted with the progress that's been made and the emphasis you've just given on sustaining that improvement and bringing new innovations, actually, that continues to be important to continue to focus. I'll just pause there and take some comments from colleagues. So we have first of all, Judy. Owen Aziz and then Judy. Thank you.
Thank you. Thank you, Chair. Jude might do this.
I know.
This is just a broad point about the role of improvement boards externally chair. I think he's right. We should acknowledge the work of Alan Thompson and Ellen Hampstead in helping us move forward. but I would really want to encourage the board to see the use of improvement boards externally chaired as a tool for the board to use moving forward. So whilst I respect our own ability to provide our own governance, I do think that there are special areas where I think having improvement boards and having that external lens to help guide us through is important, and we may want to consider that in light of some of the conversations we've had around the IPR and some areas where people have talked about having ongoing concerns about. There might be a question for us to say, is there a role for that? I don't want to make that point. I don't want to attract people and saying that we're about to have, but it was just reference I thought I'd make it. Thank you.
So
Thanks, Chair. Thanks, Faith. I agree. I think, what the Maternity Improvement Board and your team have done has been to transform our service, actually. I mean, the change in those figures of women and babies has been absolutely extraordinary. And I know people from outside are looking at your team to see how they've achieved those improvements. That's a tribute to all of you and the work you've done. As a member of QPC, we will, and Tim is the maternity champion, and then we will keep a focus on maternity. I'd suggest that perhaps actually we individual NEDs from QPC should be doing visits. Each one of us could do a visit every quarter. So, and I'm sure Tim will continue to do that. But I haven't been to maternity now for a couple of years, I think. So I'd welcome a chance to come and visit. We will absolutely keep an eye in QPC every month with you on the performance of maternity.
Yeah, and I'd just like to say it doesn't always have to be announced either. So if you are older and you're just doing something else, just pop in, because again, we don't want to be rolling out the red carpet and saying, oh, somebody's come for a walk round. It's those unannounced visits as well that always add richness. So the door is open. Just walk in and introduce yourself. And if you want one of my team to come alongside, that's fine. But the door is open.
Yeah, two things, Faye. One probably doesn't require an answer. It's probably a more important conversation. Birth rate plus. Everybody remember at the start of this year, we committed to birth rate plus in the face of a shift away from birth rate plus in the ICB. So in fact, a formal letter from the ICB saying they were not funding birth rate plus. So we just want us to think about that in the context of what Faith has said about up to establishment now, what that means for, and in the context of what Owen said about budgets setting for next year. One for us to, I think, have a conversation about purposefully. The second thing, Faith, I have just sent you the NHS sustainability tool, which has got nothing to do with the Green Plan, but it has everything to do with how you measure the sustainability of quality improvements, and it gives you put it in a kind of spider diagram, and it gives you a score. And I think it's probably a discipline that we don't have embedded in our improvement work, but one that we should have embedded in our improvement work as you step away. So it might be helpful for you to look at that and revisit it perhaps every quarter, which would give you some indication of, are we sustaining the things we said? What's going on in those domains in which it assesses the sustainability. So I've just pinned it to you.
Kind of brand new detail that we need to see more of.
I think it's helpful for when you've done a big piece of improvement work and you step away from it, because we all know that's the kind of danger zone you set. Yeah. You pay leadership attention to something else and then it all goes on. So I think I've not seen a better tool, but I don't see it used. And I think probably it is something that when we're closing something down, we should purposefully say, how do we use the sustainability tool and where do we see it on a regular basis? So maybe this is a test for us to say.
I think it's an important protest because it also aligns with conversations we've had in the past about how the deliberate learning is embedded from and as well, model that location. I think we can try and bring it together and put thank you for that. Yeah, but Chris, then maybe.
I wanted to just cross-reference back to the action log, Rafiq. I'm sorry, this is directed at you, but it's this bit where it says medical culture. There's a couple of sort of slightly openly, ambiguously worded actions there, which falls to you. I guess if we're closing boards down and so on, I just wouldn't want us to lose sight of those to that important issue of clinical relationships and culture. So I guess perhaps not now, but perhaps through QPC or some other mechanism, we can just get sight of what work is going on there. That underpins a lot of this improvement, doesn't it? Appropriate culture. It's just, I was just connecting the bits together.
Thank you, Chris. Repeat, please.
Thank you, Chair. And just on that, it is on our action plan. I think what relates to some wider dynamic existing in the team, and also to work that was done to analyze and understand the issues that we've had. There's an action plan that sits behind that, and the reason you've identified that they were appropriately ambiguous is we are just in the process of getting some assurance around the actions in that action plan. And bring QPC for further discussion. Has come to previously for a discussion. There was some challenge about particular aspects of it. So we will circle back.
I think that was if I'm remembering correctly, it was making sure that we did this in a multi-professional, connected way, wasn't it? That was the question.
And Chair, if I may, just a couple of comments on it. So just want to support everything we said in terms of fantastic work that as a team. This is really something for us and to celebrate. I want to draw attention. Also, I want to connect again, like Chris, I'm connecting. So if we connect back to what we said with our AAA report from QPC, often we know that there are indirect impacts on quality through other actions that we take or some different decisions that we need to make as a board, but sometimes it's really very tight action. And just want to point out that if you look at page 7, item 2.1, training compliance, you can see how the pressure the team on directly impacts our ability to run things like training, and a bit of doubt there as to what might happen now on the construction of this clear of establishing new dates, etc. So I think it's just important to highlight this kind of thing. But the report otherwise paints a really positive picture in terms of where we are and the trajectory on most things. I think other things that would probably be aware of in terms of context is when we talk about the patient safety incident response framework, referencing the second half of page 10 of 15, there's a comment in there which we often face, and that's look at the second line of the second row. So it's in that chart, which talks about the completion of this investigation as the investigative service part on handling study. Now, so this is completely appropriate. One of the things that in the background we've started to look at and want to work on is to ensure that just our resourcing of investigations is something that we get a better handle to understanding the flow of investigations we need to deal with and what expertise we have, and being able to direct that expertise. Because what happens now is not as structured as we should be. So that, for example, we identify there's a key investigation. I'm not talking about this particular one, I don't know the nuances, but if there may be delay because and B, whatever it is, we can then say, well, yes, should be in its entirety. So something for us to be aware of. There's a piece of work that we're going to try and do in the background to ensure that we get into a better place there. And the final comment, I see where it comes from. Again, if you go to page 9, top page, I will talk about the MRT teams. One of the things that we see often when we're reviewing investigation reports is actions that are about communication. There's one here which actually sounds reasonably appropriate. It's again, just a reminder for us collectively is planning outcome communication doesn't necessarily fix things. It's something that we will be paying a lot more attention to the action plan and the outcome, because that's the area of the team from the executive review. So final series investigation. Thank you.
But this was really significance of agency and reducing harm. It's very important. And you make it certain having colleagues available to do the structured judgment periods as well in the next paper. So there's clearly some alignment, as you said. We just need to, I'm not sure, but I would like to have some further information about how we're getting on the right side of it. Because that issues affects establishment and active ones that patient safety and compromised care. We have a list of these for under table 4.1, where mothers moving home, etc. And avoidable in the context of what we know about establishment or what we know about people non-compliant with their training or protocols, steps that should be taken. So the learning is therefore to see, but what is the assurance that the learning is actually impacting and going to be seen a reduced number of things, hopefully, in those areas that have been identified first in that table. I know that you discussed these things and you have the data on that. But again, it's about maintaining that focus and accountability as a field and also as looking at shapes and informing. So earlier on, we talked about culture and behaviours and values. That links to mandatory training and compliance. And there's also a financial issue there too, with the impact on the CST, isn't it? So we need to look at this and think more around the 24 business. But thank you for that, I think. So table and comment in the back must give you a phone to.
Oh, yeah, it's just to make sure I swept up for kind of residual board safety champion roles, because it says it's the conduit to make sure the board sees that. So it's just the kind of flag. The last walk around that Myriad joined me on was did pick up issues around that we'd also seen at QPC around infection prevention control. I think it's quite, and I think we do need to keep tracking here at QPC. Very positive one around the use of volunteers. I think I did about in maternity services. So that's one to flag. Also to note again that there is still support we need to give to Faith senior team. Some of the cultural hotspots in terms of still confronting poor behaviour, and that hasn't gone away. I think we do need to be alert, provide that continued support. The only other one I flag, the next walk around I've booked on. I know Faith said just turn up, but if anyone wants to join me on the 16th of April, that's the next day. So that was all.
Very helpful to comment in this week, patiently.
Okay, so Faith, thank you for everything you've been doing. It's great to hear that you have confidence that with our training midwives coming through, that we'll be able to recruit all of them or the majority of them. I think we need to be realistic that as much as they may look where they are, people want a job, so they will go where there is a job. And I'm aware that Bolton are doing midwife recruitment day on the 26th of this month. And it may be that is swipes us and people want to go there. So are we connecting those other events so that we are unaware where we might suddenly living elsewhere? We trained and we want them to stay, but an opportunity comes up sooner.
Yeah, and I think that is always
a risk. And I think, you know, throughout GM, there's lots of providers in a very close-knit proximity. And therefore, of the offers that we normally make to all of our midwives that we recruit to, usually there's a drop-off rate between 30 to 40% at the point of them not starting because they've been offered other providers. I think with our third year student midwives, it is slightly different because we have trained them, therefore they are already linked in with us. The difference also is that we almost give them a guaranteed job offer, so there isn't a robust interview process because we've been interviewing them for the last 3 years in terms of that training. So that usually puts us in good stead, because obviously if they were to go to another employer, they'd have to go through an interview process. Nothing is guaranteed. So we have already started that recruitment process with our third year student midwives to try and delay them in earlier. So they know that they've got a job prior to all of the other providers starting to advertise. But I think it is important that we continue to meet with them, work with them. We do monthly drop-in sessions now with all of our student midwives and do teaching with them as well, which is important in terms of building those relationships with them. But yes, it is still a risk, but we are tying them in early in order to mitigate that.
That sounds great. And I guess with our experience midwives, you know, attempt to home, whatever, do you feel that the team are aware of something that might be high risk?
Yeah, and I think that's the work that goes on through our retention midwife, but also with the managers. So we are very aware of people who have an intention to leave, and that early kind of stay with us conversation is key to that. That is the retention midwife's role within the organisation, and that's a really important post where it's somebody that's independent to the management team as well, and then feedback through, and is there anything that we can do? Why are you unhappy? Why are you looking to leave? And really try to unpick some of those reasons. Some of them we will never stop because they do want to work closer to home, or they've got family situations, or their circumstances change. But what we are seeing through our retention midwives work is that people are now leaving us to go and work for another provider. They're leaving midwifery. And that's something that we've seen over the last kind of few months, which is a real shame.
Thank you. And I know it's quite an operational question. It helps me with my assured, being assured that we are on it. So
yeah, absolutely. And also knowing when other providers are recruiting is also important. So I also saw the advert on social media. So it is keeping abreast of what everybody else is doing. I'm currently on a workforce group as the chair for GM with the RMNS. And what I would like to see, and I think it is something that's been seen in other LMNSs throughout the UK, is that joined up recruitment, because all we're doing is trying to recruit the same people, and we're robbing Peter to pay Paul. So that we need to have a more joined up approach across GM and really what we're discussing, so we don't see that drop off and people moving around.
Just one something to clarify. Okay, you said that with our trainee nurses or students that we guarantee jobs. Is that within our?
Yeah,
it is.
Yeah,
that's clear. Okay.
Yeah. Okay. Yeah. So it happened. It initially started during COVID, and all providers were asked to start that process. Many providers have continued with that, but obviously they're in a position now where they haven't got vacancies, they're no longer able to come up with that. There is an aspirational interview process, but there isn't kind of a formal competency-based interview process, because obviously we've done that during the 3 years that they've been with us.
Yeah, as long as it's built into our system, because people would have heard that and make it instant. Owen, and then.
Yeah, items related to 5.2, which is on page 12 and 15, and it's specifically a request, I think, to go up the fee about doing a purposeful impact assessment in respect of the changes in gynecology. Because the picture here around the sources last year, it describes whole women's conditions there,
yeah,
but it doesn't do is say, well, what is the impact then of any changes that we make in gynecology as a whole, which both presents potentially a risk, but also maybe an opportunity because there may be some solvent consultants, for example, who currently are not trained in maternity associated matters, but potentially could be trained, that could give us a potential capacity opportunity. So I think it's just something where I think some sort of impact assessment has been making the changes in gynecology and being purposeful about understanding what the impact of that maternity services would be a useful exercise for us to do. And then, you know, whether that gets channeled through QPC or whatever else, I think we need to do that piece of work.
So thank you, Chair. My was covered by which is actually response to the framing of multiple positive process. And I'm sure it was well intentioned, but it connects to some of the discussions we have. So I think just as an organisation, we need to do that. So we've taken on and we'll take that on board, and I'm sure we can work together on something. I do want to bring just one additional strand here, which is related to how we manage retirement in the organization. Often what happens is we have colleagues who become more senior and he retires and returns, and in the vast majority of cases, colleagues will step away from on-pool commitments without necessarily a robust plan as to how that is covered. And I don't think it is impacting maternity and gynecology in a big way at the moment. There are services in our organisation where it has had massive impact in terms of both the resilience of the service, but also really importantly, the well-being and feel colleagues who are then left with from them. It's just something that I want to put on record, something to keep on mind.
That's is that something we can frame as into the internal professional standards?
So we have internal professional standards, which essentially comes the wrong word. Advise and support the interrelationship between multiple specialties. But this is about, I think, actually just robust job time. When somebody steps away from something, just to be very clear on who's going to do that work, and do we think it's sustainable? And in making a request for return, how we view the service as a whole, rather than with one individual.
I suppose what is making professional management that multi-voice is fine. There's also the values underpinning behaviours achievement. So I think that the lines from those of those. Thank you very much for that. Colleagues, we have our last item, then we go to Raven debts. So Faith, can I thank you very much for your detailed report, and can we please note receipt of that, colleagues? The reports and others affected. Thank you. So agenda item there.
Thank you, Chair, and recognising the time standing between colleagues and a break. I'll just draw out a couple of issues just that I'd like to highlight. Questions. So things to be aware of. You find reference to mathematic review that went into the fractionating femur. That was also referenced in the QPC paper. So that's an ongoing piece of work where we're identifying where the gaps are, and are now in the process of. So there's a set of recommendations. Those recommendations haven't quite yet materialized into a full plan that is agreed. That is on action, so that's we're working on that now. Whenever we talk about this report, we want to talk about our rates of completion of compliance with SJRs. And so we're at 85%. Again, maybe not quite where we want to be, but I think in the context of the period of the year that covers, I think that's a good rate. We continue to have issues and challenges in particular areas of the organisation, and we will continue to work with them to improve their compliance in that space. And colleagues will be aware that in this forum, in the past, we have talked about our coding challenges related to the lack of wide availability of that expertise. And you can see how it is sometimes impacting some of our work. And there's reference in there about the lack of depth of coding, potentially then impacting on our mortality outcomes because we haven't captured the best individual patients. And so when you don't risk adjust, mortality will go off. Broadly speaking, all our metrics have continued to go in the right direction. And colleagues will we've had discussions about the importance of not being complacent. So on one hand, I think it absolutely needs to be celebrated because if you look at our metrics, we have had a sustained period of improvement and stability for at least 18 months there. So something you should absolutely be celebrating and thanking all the team to do the hard work to keep us there. But we are keeping some. The out of hospital GP data is going in one direction. This work ongoing at the moment to try and understand why specifically for magnitude Oldham and Bury, that's not quite, we're just on the wrong trajectory there. So we need to come back and report to that this work is completed. Another couple of things just to sort of emphasize. Top of page 3, there's item 5 that you can see there. We're just wanting to ensure that we move from a reassurance space on some of these things to insurance space, where there's easy access to all the evidence of completion of things that come out of our reviews. So there's that. And another just theme that seems to be emerging as well is deteriorating patient approach isn't consistent and maybe not as robust as we want it to be. So there's a bit of focus that we need to go into this moving forward. Other than that, I think there's a little bit more detail on plans and certainly some of the themes. The final thing I want to draw your attention to is the piece of work that was done related to health inequalities and just the profile of patients. I think this is really interesting work. It's the little seed that we're planting in terms of trying to understand a little bit better the patient, well, the community that we're serving, and how it impacts things like our mortality. And really interestingly, starting to show us that maybe some of the standardized metrics used nationally may not necessarily capture somewhat of the context. What we need to think about is how we capture that and ensure that it starts to inform what we do moving forward. In the context of us saying that we want to focus on population health, understand that, etc. So the mortality side of that, I think, is a useful one. One thing to say, medical examiners doing a really good job, 100% compliance with everything they need to review and celebrated by some of our mortality partners in terms of the we're seeing in for. Thank you.
Thank you. Just let's get to go back and talk about the sheet or will that be available?
So I would expect it to be as a part of our next report. Yeah, I expect it to be just go through. So the report needs to be completed. We need to go through running from that and as part of this report.
Chris and then Jude.
Thanks, Chair. Rafik, thanks, great reports. One thing that we picked up before the board, but I think comes out of what you've just said, is really understanding why those mortality figures have improved at the rate they have. Call me skeptical if you like, but that is I've never seen anything like that. And I just feel that needs, and I know you've got rest of the place to explore that. The reason I'm raising it now is that I'm just linking it with the comments on the coding, because presumably if the coding was better, these figures would be even lower. So even, I mean, that's the norm, isn't it? If you identify comorbidities, you standardise better in the rates. So even more so, what's going on? Are we, the other thing that's just in my mind is that as I understand it, in the performance framework that's out for consultation, these things loom large in terms of the way that we will be assessed in the future. So having this locked down properly is going to be, I think, really important for us. And I guess, I know you've got some process in place to answer those questions, but I do think they need answering.
Thank you, Chris, and I think it is absolutely something that we should raise and discuss. And Owen specifically has challenged us a few times on this, but I think that doesn't take away from just if it was something related to a bit of a blip in how we approach things, or something related to manipulating coding, whatever. I don't think we've seen that level of consistency, 18, because remember, it started, I don't remember the exact date, but you can see us making very significant improvements about 18 months ago. Now, at that point, that will have been the 12-month rolling data. So that data will have been for 12 months before. So we've had quite a sustained period of very reassuring data from that perspective. However, we are looking at it in increasingly close detail. We are speaking to the providers of head who essentially collect the data and crunch it nationally in terms of characters to try and understand some of the nuances. And Owen has put us in touch with one of the national leaders really in this space in terms of understanding mortality statistics. And we're just in a conversation with him now about him coming to do some teaching and a piece of work to maybe try and dig into it a little bit. So I maintain, I think it's very reassuring data that has been consistent, but we are taking on board the point that we can't be complacent and need to put it.
So if that's real data, if that's true, then the reasons for that need explaining to people who are.
It's a little bit difficult sometimes because mortality is, there's so much that goes into it. That connectivity between what we're seeing here and what has happened to all our patients, 12 months plus before, we found a bit challenging.
So maybe to support what Chris says, is that the clarification around the reduction or the increase revenue is explained clearly.
Yeah.
Because coding is really one we do need to keep. Owen, and then Jude.
Absolutely know that it's head and heart that when Chris made that point there, he went, oh no.
That would be my response to NHS.
I have to say, I think this is what we just need to keep going at until we've got assurance. Some things just so you've got coding issues, challenges. We know we've got coder resource issues that sit because normally, because you're right, usually when you see an improvement, usually it's usually on palliative coding and wetlands, but there's usually some sort of coding adjustment that starts to see an improvement. You can articulate that when. If you just triangulate, let's take our emergency care performance, that there is an increased risk to people of what happens in UVC, for example. So we know that there are backlog of things that we still need to work through. There's just several points of data, and together with the out of hospital bit is kind of consolidated in that piece. And if that is starting to go off, it's still boggles my mind then how we have this trajectory. I won't go on because the beat's probably eating me on the table here, and I know we said that this was the last item before we have a break, but can we just say, can you blame Chris?
Yes, absolutely.
I'm happy.
Final question for you.
Yeah, I probably should have spotted this at QPC, but there's never anything in these reports about child deaths. So we've reported child deaths, but it doesn't feel like the learning, because we know that child deaths go through the child death review process, but we don't seem to pull the learning back in And I don't know whether our medical examiners are equipped in looking at child, you know, I don't know if they input into the child death review panels or how that works in terms of bringing the learning back in, because we don't pull it into this report. And I know, you know, we know we've had child deaths.
That's a really good comment, actually, and
Better than
it's not the competition. But sure, that's a really good comment there. We probably need to dig in a little bit more because the child death review process is a very formalized external process to us. Our medical examiners are equipped to look at child deaths, but as far as I know, I don't think they directly input into the child death review process itself. And so probably I'll take it away and do a little bit of considering, because there's a possibility we sort of see this robust process here, and so are maybe not fully.
It's the learning.
Out of
I
it.
don't know where the learning comes in.
So I'll do some reflecting on how we improve that. Thank you.
Okay, thank you, colleagues. Can we please accept the 2024-25-43 learning plan? Thank you. We now have come back, so we can start with the gender items of the child, people in
Jude, Sue, we're beginning.
Sorry,
with you.
I wanted to wait for them. Okay, so the People and Education Committee met on the 19th of March. I'll just quickly go through the alerts though. A resourcing update. The committee congratulated the resourcing team on the work they've done over the last 12 months, which includes significantly reducing time to hire and improved candidate experience. As discussed earlier, the NCA KPI sickness continues to show a steady increase and is now at 6.69%. Actions have been taken to address it. I've had a chat with Jude actually after the governor's meeting and the staff governor from Oldham, and there was some, discussion about the figures. So I'd quite like Alex Garbutt to come to People and Education Committee just to take us through, so we are all on the same page on where the figures are, where they were, what our improvement journey, and then we can discuss our improvement journey. And I think it's really important for staff, for the exec, and for everyone and governors to be on the same page of where are we trying to go. It's clear that whatever the reasons, there needs to be the wellbeing programme we need to focus on, the return to work, and it depends on managers doing what they need to do, but those managers need support. And there are areas of the NCA where they've had training on this new sickness policy, and that's what the staff governor was talking about, the new sickness policy coinciding with this, or saying it coincided with this increase in sickness. Well, I think that we need to clearly offer manager support, because what needs to be done is not happening. And, we can worry about it. We need to help the managers to manage this, I think. And that may involve some bite-sized training they've done in some areas like Berry. We received the National Staff Survey results. We're going to discuss that later. We discussed it earlier, so I won't say any more about that. It's great that we have 55% of staff telling us what they think. It's now vitally important with that huge response that we act on it. And at People Committee, one of the things I said is that I'd like a quarterly update to People Committee on the action plans, because we heard last year that some of those action plans didn't really go anywhere. We are going to ensure that now the staff have told us what they think, when we set up the action plans, we stick to them, or and we will monitor them through People and Education Committee, and I'm really committed to doing that. I think, and there was an advice which we got the committee, received the quarterly apprenticeship report. Work is ongoing, developing an early career strategy to ensure we maximise that levy spend. And we also discussed the fact that the possibility of restarting the nurse degree apprenticeships, which had been stopped. And, you know, I just think apprenticeships, we all know the cost of university degrees, and, you know, it'd be great if we could look at starting the nurse apprenticeship scheme again, because I think we'll get, you know, a different cohort and a better response. And there was one approval of the fit and proper persons policy, which has been updated. Thank you, Chair.
Thank you very much indeed. These were comprehensive updates. I think that your focus on understanding not just what the action plan contains, but whether it's on track. And when it's not on track, we understand why it's not on track. And that's reflected also within our backlog. Thank you very much. Are there any comments or questions for colleague business? Good.
Yes, thank you. And it's unfortunate I wasn't aware of the conversation you and Jude had after the council companies, because I would have to say, just for clarity for the board and the minutes, it wouldn't be for Alex to speak to sickness rates. Those are rates that we provide him as a people function. So just for clarity to minute, if there's an action to transfer to people in the education community, that would need to be for myself and Estelle to bring in a longer term view of absence. And we've talked this morning about the work Juliet has been commissioning and the development and training for managers. So I think you're right, Aziz, it's the right place to have that conversation is in the People and Education Committee. But just before we give poor Alex a job that's not his to deliver, it would have to be for myself and for Estelle and HRDs, etc., to bring that back. So I'll add it to the next agenda.
Thank you.
Is there any further questions? What's a clarification? Sue, thank you.
We're setting a huge amount of store on the welcome back conversations, aren't we? That seems to be our big ticket item to reduce sickness. What else are we doing to reduce sickness?
So I would say it is the big ticket item. At the moment, we've got about a 20 to 30% compliance rate with welcome back interviews, and all of the research, national research, King's Funds, etc., will tell you that a timely and supportive return to work has a material impact on reducing future absence. Keeping in contact with colleagues who are off sick helps them to come back earlier. So that for me has to be the big ticket item, because we're not getting the basics right. Alongside that, if we reflect on the staff survey, the colleague experience conversation this morning, it's making people aware of the various support available for them. We've done a lot of work, and I'll come to it now, on flexibility in the staff survey and increasing flexibility so that we can help people manage and have that balance between work and life and their external commitments. So there are a range of activities, but if we're not getting the basics, the foundations of caring for our staff right, all of the rest of it falls down. So for me, that has to be our big ticket item, and it is simply not happening. And it's not happening timely enough or at all in the main. So we can see that really needs to be gripped. So for me, it is the big ticket item.
And does our policy provide for ultimate dismissal for a poor sickness record?
Yes, our policy absolutely includes a process to manage and support colleagues through both short-term and long-term sickness. I mean, there's lots of conversation about the policy, and there's always a running narrative around attendance. If we look at the figures, our sickness rates were unacceptably high before the policy. They've been unacceptably high back to before COVID and above what we would want to see as an organisation. There hasn't been a material spike in the time that the policy was launched. We have seen the usual seasonal variation, for example, over the winter months, which we've talked about here and we've talked about in the committee. But it absolutely has a process by which colleagues are managed. The issue is, as we've sort of said, and the feedback from Juliet and Aziz is right, it says whether colleagues feel confident and able to do that. So that's why the focus on skills development for managers, drop-in surgeries, etc. We're taking through that piece of work with Juliet.
Yeah, it wasn't so much a policy. I suppose it's, do we have a stick as well as a carrot?
Yes, we do.
Okay.
Thank you, Sue. Juliet.
Thanks, Chair. I just wanted to build on what Gertie was saying. So obviously we've got one of the biggest workforces in nursing midwifery. The focus piece of work is, as Gertie said, there's two things: is understanding is our environment contributing to sickness absence for our workforce, in which case what are our interventions, and then the other is what can we learn when we have those conversations. So what else would it tell us? So I think this focus that we've got now with the training that Gertie's team are going to put in and support into certainly the nursing leadership around the management of this is going to tell us what more we could do. Because I think to your point, Sue, what else could we do? I think we've got quite a number of things that we could do, but I think there's a little bit more learning yet we've still got to undertake, and some of those might be just kind of practical things that we can do to support people in remaining at work. Shift patterns could be something, we might want to look at. So there might be some things that the more we have these conversations and the more they appear to be conversations which not appear to be, but well, appear to be and are about well-being, not accepting your comment about where can it end up. That's where we're going to get the insights, I think, into what else could we do. I just don't think we probably have to focus on it. It certainly hasn't been in nursing and midwifery. So I think more will come out over the next few months about what else we could do.
There's a real correlation for me, actually. So, I'm looking at my board pack, and right on the bottom of my board pack, under the alert, we've got our values and we care, appreciate and inspire. You then triangulate staff survey response, behaviour, whether that's going to Women's Network, going to a racism workshop. Our staff are telling us that there's behaviours and customer practice in this organisation. So while we can't put 100% stock on a welcome back conversation, it is about drilling in those values. So, whether it's a quality conversation about I care enough to fact check that you're okay, I care enough to check that actually there's an intervention needed and I'll do something about it if there's an issue, so performance management. But there's something about collectively how we instill that behaviour across the piece at every level. And colleagues feeling safe to raise concerns, it's great, we can see some uptick. But we also know from sitting in a workshop about racism that there's a whole load of colleagues that currently still don't feel able to do that. The behaviour they're seeing does not correlate to some experience. So for me, there's a drip feed, isn't there? It's not one thing that would be a magic bullet to address this. But the more we embed what good practice is and really embed the value piece, really helps. And then the more we instill the need to be able to then have the difficult conversation, the stick moment that says, well, if I've done and lived to my values and I'm caring about somebody, I'm appreciating what the issue is and I'm still not getting anywhere, then we have to hold true to performance management. So it's not a HR issue to fix, it's a behaviour from every person in the organisation. But we've got to do things that create habit. So a return to work, welcome back conversation. It's really interesting. I sit as a trustee on a hospice, and it's a much smaller organisation. I think you're talking about 500 people in total. They're also seeing high levels of short-term sickness, ringing in before a shift. I'm poorly, I can't work today, broke my thumb or whatever it is. They're having those exact same conversations and they're having the welcome back conversation. And that plus updating their values, plus embedding good behaviour, plus starting to define what good looks like, is starting to address the dial. And I think we've got to keep going at this and we've got to keep looking at a layered approach where it feels, the alert is a really good highlight for me about, that is all about how we live our values. And it's not one thing, is it?
Thank you so much. Aziz, do you get you coming back?
Oh, sorry. Thanks, Lorna. And I think that, you're right. And, we are looking at so many different aspects. And I think the reason why Gertie, is emphasising return to work is it's at 20%. And, sometimes when you're communicating in an organisation, it's really important to give one clear message of what you need. But a lot of other stuff is also happening. I want to assure you of that. And we talk about it a lot at People and Education Committee. Gertie, I was talking to Jude because the integrated performance report had wrong data. Yeah. And Jude and I, that's why this conversation began with Jude about data. And actually, you've said twice now, you said it's in Council of Governors, you've just said it today, that it's always been unacceptably high, the sickness at the Northern Care Alliance. That's actually not how I see it. I sat on the chair of People Committee and we presented reports to board where we had falling sickness over an 18-month period where it went down to nearly achieved our target of 6%. steady falls. You may all remember that. So we have done this before and we can do it again. That's why I wanted Alex to come and talk about the data, because I want us to be on the same page with that data. And I don't feel we are at the moment. So I thought having someone who's a data supremo coming in and just talking, because I may be wrong, and so that we can all be on the same page, because we have to have one story that we all agree on, so that we can begin our improvement journey. But it is all about supporting managers and manager action. But I do think having a focus on one thing is a very clear message, actually, and it's really important to have clear messages sometimes when there's a lot going on.
So there's something like that clarity, and with all of this, we start from a balance based approach. You have to, because we care about our clients, and we want to understand what's impacting upon their well-being, what's interfering in their life that we don't know about. Because if we know about it, we can accommodate and support. So again, so a push for people to connect with well-being conversations, to respond to that surveys, and to keep going forward, and for us collectively to create a culture which is compassionate and caring and values-based. So that's something that we need to. Thank you. Jeff.
Yeah, just a quick one. Picking up on those comments, what's the correlation, if any, between sickness and disability, sickness and incapacity?
Didn't catch all what's ending.
You might.
Jeff.
So I was asking what the correlation is between levels of sickness and staff with disabilities, and levels of sickness and staff on paying backgrounds.
I think we'd have to take it up the way, Jeff, and come back to you with a detailed answer, because I wouldn't be confident on doing it on the hoof now. So I can pick it up and come back to you outside of the board.
The reason I'm asking is that we always got the staff survey. So important that something this organisation have to experience. I'm not saying that, well, the return to work isn't even a competition, nevertheless, you look at subjective, look at the data, that might tell you, in addition to that, some things, or some, if the evidence.
I think that's is what you learn on the basis. Thank you. Because you can.
Yeah, actually, so I didn't understand where you were coming from. Apologies, Jeff. So what I would look at is to say, actually, I will come on to it now as we speak to the staff survey, is we see that our colleagues with protected characteristics across the field have a materially poorer experience than their counterparts. So there is triangulation that we do around that. And again, it comes into the People and Education Committee. So we do specific targeted pieces of work around that. I can't give you the figures, but I will come back to you with those. But what we can see is the experience. And if you look at the staff survey, people feeling the pressure to come to work when they're not well, people feeling that they have a worse experience when they have a disability or a long-term condition. So there is triangulation with that, but I'll come back to the specifics outside.
Thank you. Joe, you have the last comment. Yes. Please use your mic, colleagues. It's struggling to hear. Joe, please.
Yeah, thanks, Chair. I have to say, listening to the conversation, I say that I wasn't entirely convinced by the emphasis on the welcome back and the return to work. I think maybe because of the naming of them and what they represented. But I think there is something really terribly important about it, because I think there's acts of commission, aren't there, as managers and leaders, and then there's acts of omission. And we all started somewhere in organisations, and I feel if I 30, probably 40 years ago, when I was starting work, if I'd been away for any reason and my manager wasn't interested that I'd been away, and they didn't ask me how I was, so I'd call it a "how are you" conversation. How's it been? I'd feel I'd definitely take the message they didn't care. They didn't actually notice whether I'd been at work or I hadn't been at work. And so as a litmus of how people are feeling and the quality of management, I think it's a rather stark one. And so I would actually fully support the need for training, the need for managers to manage, and managing is looking after the people who you've been asked to manage as the fundamental number one. So yeah, I think it is a big push on that direction. with other things that are wrapped around it, as Sue and others have pointed out. But yeah, it's about caring for the people who are working for you and looking after them. Thanks.
Thank you, Jude. So can we conclude this item, please? And can we please acknowledge receipt of the educated committee? Thank you, Louise. We'll move on then to matters first grade. Agenda item 12.2. Betsy, National Staff Sufficiency.
Thank you, Chair. I'll take the slides and report as read. There's a few elements I'll pull out, and I will try to be quick because obviously I appreciate colleagues want description afterwards. We have covered some of this already, but I think we should recognise that our response rate was at 55%. And for us, in terms of numbers, that means over 11,000 colleagues share their feedback with us. And that's incredibly powerful. And Aziz has already said it, Owen has already said it, it is now fundamentally important that we say, this is what you told us, we've listened to it, and we will do something with it. So that is the challenge for us. And I think for us, the challenge is that we relentlessly connect all of our conversations back to the staff survey. It's not once a year, it's every day and every month that we need to be responding to that feedback and actually visibly showing our colleagues that we are doing so. In terms of the highest scoring areas, the highest areas where that we are compassionate and inclusive, we are a team and staff engagement. The lowest scoring areas are that we are always learning, staff morale, and we are recognised and rewarded. One of the areas that has seen a significant improvement, recognising the work that has been placed on it, is we work flexibly. And if I connect that to the conversation we've had just about attendance and sickness, being able to support colleagues to meet all of their various conflicting priorities in work, out of work, to meet the needs is incredibly important. And that's, again, we come back to, we talk a lot about personalisation for our patients, but we need to be personalised about our colleagues. You know, as Joe says, the how are you conversation, the what do you need, how can we support you conversation. So it's really positive to see movement in the right direction. Not all the way there yet. We absolutely have a long way to go and can do more, but it is really, really positive to see that. I think if we again reflect on the colleague story this morning, the way that Kim and Emma articulated the flexibility they've been putting in, the support and so on, really, really brought it to light for us. In terms of the most improved care organisation, diagnostics and pharmacy are the area that's seen the most improvement, and the highest scoring care organisation is Rochdale. So there's some real positivity in there. We do need to measure that, of course, because we have seen across 8 of the 9 areas a slight decrease. And I think for us in the year, particularly the NCA has had, in the year the NHS has had, I'm not seeing that as a significantly negative position. I think that we've broadly held the same in a year where we've delivered a significant CIP, as Suzanne's talked about this morning. We've gone through a corporate target operating model. There's been a huge amount of change nationally, government, NHS and so on. So I think that's probably something we could reflect on with positivity, but we need to challenge ourselves to do more. We are average or about average, and for me, I want us to be beyond outstanding. So it will be a 5-year journey to get to that. But I think it starts with every action coming back to living and breathing our values. Key few areas I would like to pull through are freedom to speak up. We have seen a slight decrease in that. That's echoed nationally, so we're not an outlier. However, for us, if we think about the feedback we've received through the Breen report and other areas, creating a culture, creating an ethos where our colleagues feel they have a voice, that they can raise concerns, also that they feel they can make suggestions about improvements that they can work to be part of, to developing the organisation as we move forward, is really, really important. And for me, speaking up is absolutely at the heart of our culture and is about how we live our values. I've mentioned it in response to Jeff's question, so I'll probably summarise a bit more, but we can see in the workforce race equality system and the workforce disability equality system, that our colleagues with protected characteristics are telling us their experience is significantly poorer. And I think if I pull out specifically our LGBTQ plus colleagues and our colleagues with a disability as being a highlight for us. So we have been doing a lot of
around the last couple of years around improving the experience for our Black, Asian, minority ethnic colleagues. And we've seen some improvements, but again, we have a long way to go. But there is positivity that we're getting in the right direction. And that again gives me positivity and hope that we can make those interventions for our other colleagues with protected characteristics. We have seen a variance, and you can see that in terms of the slides across care organisations. And again, that provides us with a great opportunity to share really good interventions. If we think about this morning's colleague experience, we've also had previous colleague experience from other areas in the organisation where they've really seen a shift in the staff survey. So there's, we've got pockets of great practice that we can share and learn across. I'll pull just to then the key focus areas. So 4 of the 5 key focus areas, colleagues included in decisions and being able to contribute to improvement, freedom to speak up and colleagues having a voice, not experiencing violence, harassment or sexually inappropriate behaviour, and an improvement for the experience of protected characteristics. They are the 4 focus areas we had after the 2023 staff survey, and they continue to be material if we reflect on the feedback colleagues have had. And experience takes time to improve and to change, so they will continue on this year. What we've added this year is a 5th organisational level focus area, and that is that we treat each other with kindness and understanding. One of the key themes coming through the free text in particular is that our colleagues experience a lack of civility, a lack of kindness, and microaggressions from each other. So really focusing on the behaviours that live our values. And Julie and the team have already done and started some work about how we reframe the values and the behaviours. Our values are our values. Care, appreciate and inspire are absolutely our values. But when we did the engagement work with colleagues around that, they gave us lots of feedback on how we live those values. And I think it's about how we simplify that and make it a message that everybody can connect to. What are the behaviours that are acceptable? And really importantly, what are the behaviours that are not acceptable? So we know our standards in the organisation. Each of our care orgs have been asked, rather than developing a huge big action plan, that they focus on one theme, one key area, and pursue it relentlessly to make a shift, to make a difference. As Isa said, we felt in the People and Education Committee that we created big action plans and they weren't delivered. And there's nothing worse than asking somebody what their opinion and their experience is and then not doing something with it. So that the ask to them for care organisations to focus on one single theme will give us 5 organisational areas and 6. So we'll have 11 in total, which actually I think is about right for where we should be. And again, that we communicate that, and we've agreed a process by which we'll receive updates from each of the care organisations in a standard format through the People and Education Committee. So again, there will be more robustness around how we do that. I'll leave it with that, but happy to take any questions.
Thank you, Betty. That was very helpful, very comprehensive. I'm sure there's got some comments and questions. Chris, you happy?
Yeah, thanks. That's good. I'm clearly there's lots in there that we should be very pleased with. So the point's been picked up. Well, the bit I can't square in my mind is the statement. Actually, you just said it as well. This statement F in the introduction, which says that things have been getting better, improvements for our Black and ethnic minority colleagues, and I can't square that with the data that's in the table.
Yes,
because if you look at that data, you have to do a bit of mental calculation for the gap between what it describes as white colleagues and the gap between and what it describes as other ethnic groups. If my calculation is correct, it's got wider since 22.
You're absolutely right.
So it must be all the data that's on the basis of that.
So we've got just a selection, a high level view of some of the questions, and I think they're worth sharing because they are the ones that most starkly show the experience. There are a number of other questions that we measure in both the workforce race equality and the workforce disability equality where we have seen a shift, and I'll call it a shift because it's turned and going in the right direction. It could equally turn and go back again, which is why I say it's a start, but nowhere near where we need to be. The experience is still materially poorer. it's slightly less worse than it was, if I say it that way, but it's still not where it should be.
Okay, well, if that, if I still got quite, on the basis of the data we got in front of us, that's not the picture. And you know, there's been a couple of comments previously about lived experience and workshops and so on, which happen. So I guess if this is going to be looked at elsewhere, it'd be important to consider that whole picture rather than just this specific bit of data. Because at the moment, those two statements seem to be at odds with each other, but there may be other things.
Thank you, Chris. Next. Suzanne, sorry, Suzanne. Thank you.
I mean, it's just such a valuable insight, isn't it, for us to the board, isn't it? Again, lots of paying attention to it. It shouldn't go underestimated, but just to draw out, you mentioned it already in your summary there, Gertie, the one touched on it too. But that one around particularly ensuring that our colleagues feel safe to speak up and confident that we're going to listen to them as an organisation and as a board, and extending that to the reporting of incidents. When we're in an environment where there's a lot going on, that becomes critical because the organisation becomes our eyes and ears on keeping us safe. So it's, despite the having multiple things to concentrate on, we sort of ignore that at our peril. So it's great that it's in here as one of the priority areas, and to be relentless, which I'm sure it absolutely will be through that action plan, about how we keep focus on all of those things that make that actually bear the results we want. So the signposting, the regular conversations, the open and transparent dialogue, whether that's through values or return to work, understanding the barriers as to why people don't speak up, where they exist, who they affect, really promoting that psychological safety that we want to encourage within the organisations. All of those factors are just so important, aren't they? Because we're going to have another challenging year that comes in 25, 26, and we'll need that.
Thank you, Suzanne. It's only Jack.
Yeah, you know, it's, as we last year, our book, our MT, I think nobody said I'm not kind of happy with average. I don't think that should be our aspiration around this, and whether we can kind of wait 5 years that to happen to get to this one, be probably at least 2 years longer than people, except it's a cultural piece in this and some of the challenges we face indeed. It is worth pointing out, I guess, that at the time this survey, redundancies were being enacted, which isn't common for us. And all the car parking drivers were being introduced, which again, so there's some context around this together with £85.6 million cost improvement planning. There's a context to it. Probably less hidden in the data, probably less visible in the data. I think though there is a theme about leadership. And I think that is a strand that we can't ignore. And some of that is, and the reason why I spot it is sometimes what you get people with management rather than leadership at the moment, but you get proximity management. So the line manager who, is one step removed from me, I tend to be more favourable about. And then the people who are further away, like a chief exec or an executive or whatever, tend to be less favourable about. I think our data is probably showing that across the piece, we would want better relationship. We would want our colleagues be more positive about the leadership that they get. And then I don't divorce myself from that. So I wouldn't want to leave this conversation without at least that being on the radar for us. And that's why things like the leadership development work we're doing, accelerating leadership development, the targeting and clinical leadership, we also cannot forget people in operations, safety goals, and the leadership that we're going to be asking them to apply on £110 million cost improvement journey, where we know that there may be reductions in workforce dollars profile. So I would also just say, as well as the broad themes the journey is articulated, a continued focus on leadership, and particularly the visible aspect of leadership, is going to be quite an important component. So I want to do that to the conversation.
No, it's a really helpful insight. They can't really with them handed on. Thank you. It's
Right, thanks. I want us to be really clear. I'm really glad that we are focusing on, staff with protected characteristics. And I want to be really clear about the data that is right in front of us. The workforce rates equality system. Percentage of staff experiencing harassment, bullying or abuse from patients was 22%, has increased to 29% in a year. Percentage of staff experiencing harassment or bullying or abuse from staff in the last 12 months was 23%, has increased to 25%. Percentage of staff in the last 12 months personally experienced discrimination from any of the following: manager, team or other colleagues. White colleagues, 6%. All other ethnic groups has risen from 14.5 to 17.22%. There is only one category, percentage of staff believing there are equal opportunities for career progression, grade, which has improved for all other ethnic groups from 43.8% to 46%. These gaps are bigger, and those gaps that also exist for our staff with disabilities. But the figures for staff with disabilities are not as disparate as those with white colleagues. I think we need to be absolutely clear on that, because we need to focus on that and to improve that situation.
absolutely clarity in extreme. Jeff, you have the last comment.
Thank you. I'm really good to Chris, and particularly what the sister just said is exactly how I would have thought. You cannot say anything else because it's there. My question was about what Owen said about the books of leadership. What was really interesting, where you analysed where the leadership challenge is. And to be frank, I've seen fantastic programs and initiatives on the response in the NHS for decades and decades. And we were really impressed with them. And yet, it's still in this organisation, in this position. And I just wondered whether, in our focus on leadership and how we collectively meet all those challenges around performance and finance and quality, whether there's an opportunity to build into that other modern way. That it's in a values there issue, isn't it? Do you actually get it? And are you personally to provide the leadership so we turn these things around? And I don't know, I'm not saying, so I'm saying whether you think there's an opportunity through that bunch of leadership to have more of an impact on these disability around race and disability than you have done before.
Yeah, and again, there's a thing you need to figure out, because if I take somebody with disability, if you listen to our disability forum clients, I'm for it's great because I'm automatically connected into that forum, so I get to see, particularly on MS Teams, what the traffic is and what people are discussing. And I would talk about application minority ethnic colours, and of course there's intersectionality where there's things that join on that. One of the leadership things we've got to develop is keep going back to these groups and asking them, what do you think, what is it that you need to see happen and stuff like that. And you won't be surprised to know that I think some of these they're just fatigued by that. And they're kind of looking at the people and those like him and Becky saying, when are you going to do your bit around some of this? And I think that's the leadership space we need to occupy. It's like when I was talking, for example, about the sort of leadership bit. There's a bit where some people, all of us, need to step into that leadership space, but we need to help colleagues understand what it looks like. It's fantastic seeing the reaction in the sense of, when people experience the pain of colleagues in the anti-racism framework conversation we had, and people were crying along with them, and people were experiencing the pain. That's great. But once that meeting's finished, if there's no behavioural change in leadership, okay, if that conversation when you return from work is different for you as a black person than it might do to somebody who's not black, and people talk so people understand what those conversations are like, that is the leadership space and leadership development space that we need to get into around that, and that's where our programs need to be edged towards. I would also say, and I also keep on about this, you heard me talk about the anchor people piece and seeing people more broadly than who they are. That is, I think, our golden opportunity to really have a different conversation that I don't believe is really being had in the NHS public sector more broadly. Or Andrew Stallard won't mind. But, you know, the one-to-one conversation with Andrew, yourself and Fisher came with me. I was having this conversation, and of course we all know Andrew was, you know, the care org lead for D&B, stuff like that. But he's also training as a triathlete. He's also an under-30s football coach, and he's got other things. He's a governor. There is more to him than just a D&P coach. And if you speak to people like him and just ask the question, if we celebrate and recognise more of you in that broader sense, would that feel more, create more of an honoured opportunity than if we just keep seeing you as a member of staff of Band 6 or whatever? And most people, not for everybody, most people see that as something that might create perhaps a different bond around some of this. And I passionately believe to change some of this around, you have to get into that space. You have to get into that space of seeing people beyond protected characteristics and seeing the rounded person and having a rewards and value system that recognises the broader sense. So when we're on the staff awards, for example, a future where we're recognising the broad person just as much as we would do a person doing that specific job in the organisation. This is our opportunity, and you know, Gertie, we're going to be bringing something forward that speaks to that, because I think our broader people strategy should be described as an anchor people strategy. God, they have elements like SCARF, but you heard that today. You know, very important things. They do work. Need to make sure. But the additionality, I think, here is seeing people beyond just the role, because we are entering out of it. It's so evident. We're entering a different space. And, you know, for those people who are familiar with Michael West and so on and so forth, I think that it's very hard to argue against almost anything that's in the West worldview. However, we are in a different context, particularly post-pandemic. There's just something about we need to recognise that in our people. So I hope that we are, no hope's not a plan, but I do want to see us make some movement about some of this, because it's an opportunity for us to lead in some of this, and it's an opportunity to do it in a way that I think will help people in the less shift, 3 less shifts, a different way of looking at it. We need to grab the space.
Okay, I know that. Susanna John, Susanna Mitchell wanted to come in by actually going conclude with a really balanced and insightful discussion, but we need to make it clean. We need to live and breathe in our response to the survey. I think there's a connection there, isn't there, what you said of different seeing beyond the characteristics. I haven't heard anyone say what it's like now on the way home. People with protected characteristics, disabled people or people of colour who leave this hospital society, who are looked after and cared for maybe, and hopefully they are, still they live outside and they could be wearing their badges or whatever. They are abused. And if you look at these statistics on hate crime, there's 60% increase of hate crime against people. And So there's something within our conversations that needs to connect with their lived experience outside of our. Also, the way in which social media destroys lives, actually, and not just those individuals who are caring for loved ones, but their loved ones who may be younger children are experiencing this every day. And then we have night crime events are happening. So there's lots of different elements to this. But I really go to, if I may, and I know they've captured quite a lot of detail in the discussion. It would be really nice to have some reiteration to the people education people who've had that come back to board about what we are going to do next in response to what we've heard here, particularly the people, and also our aspiration to step up to silver on the race equality, the anti-racist radio. No, we can't just say these things like that. If we're at bronze, that's fine. We want to have aspirations to move beyond bronze and what's going to get us there, really. So thank you very much, colleagues. That was a very helpful, informative discussion. Answer and Peter. Yeah, we're slightly out of things at the moment, so we're delaying the agenda, but we'll come to you as soon as we can. Thank you. Our next, so we've closed off the National Science Survey. Thank you, Gertie. Research and innovation. Common, will review that.
Thank you. I'll try and keep it brief. We met on the 26th of March. This was an extra meeting of the committee to discuss outstanding items on the work of this year that's just ended, and to look at what we need to take forward into the next year. And the alert that I draw your attention to is the conversation we had about health inequalities and the concerns, risk about whether we can deliver our ambition in this area, because the team that exists is a one person who is 0.6 FTE, has had some analytical support until now, project managers, but has got a proposal that she believes will help us achieve our priorities in this area if we can find a way of funding some additional resource. The proposal was based on 108,000 per annum, and we all know that we don't have a magic purse. We can't just find this money from anywhere. So there were a few ideas explored, including can we get some fixed term roles funded by charitable funds, which will be explored a bit further, and we need to make sure that if we are going to support this and go forward, that we have a business case to secure improved funding. But I do want that noted, that this is a concern, and we all have agreed that in our priorities of 25-26, health is one of our priorities. How we're going to do that with what we've got now is a challenge. We also discussed in relation to that matter that we would invite Crystal International to come to board and present at one of our board meetings, so the opportunity to have in-depth conversation. We can discuss that. Under advise, the strategy group continues to research information committee and particular. And I would note that in cross-community connectivity, the request of the Charitable Funds Committee, we did spend a bit of time on the last R&I committee looking at a recurring research patent that North Care Charity were trying to get some answers to. And we're going to ask the R&I management group to do a deep dive to understanding what 35k payment has been spent on. So what's happening with report of that, what the higher is, just a financial information. That's all I was going to call out at this point.
That was really comprehensive. Thank you so much. Research and innovation is a tremendous work we do. Recognise that and acknowledge all the good collaboration that's going on. The thing highlight I think is this exciting one around health and inequalities. We've illustrated today in this conversation how important that is and very evident it's having benefits for us. So I do feel a business case which supports what you made should be drawn. We should consider options. Suzanne, we can
Our main concern is that typically business cases and their payback period would be shorter only focused on shorter time and research might deliver impact. So on, then it might look on paper that this is going to be back in. So you just need to pay attention to that.
Yeah, absolutely. It's important. Yes, it's not very thin. So I think that's the recommendation.
Thank you.
Thank you very much. Are there any words of clarification?
Yeah, thanks. I'm just, it might be a question for Joan Repeat actually. Do we set the research team an income target? I'm thinking about commercial income and I'm thinking about the financial position going into next year. Because if we set them an income target associated with bringing research income in and commercial to funding some of the things that we want to reinvest that money in, but it's also, I'm not sure I've ever seen it feature in the SIP plan as a contributor.
Quite financial. The contribution, we don't. We'll be looking at it a lot more carefully this year at the challenging landscape that we want to tackle. But if you have conversations about the commercial aspects of research, that should be looking at this slightly differently.
Any further comment? No, can we?
I wanted most was just I thought we'll go back to the point that we discussed in the introduction of Carmen's report around population health resourcing and recognizing everything that Carmen has put in it. The only thing I would like to add is we just need to recognize that we have said that we have health equality population objective. You said that organization, better than 10 as a what we are going to do. And one of the things I'm concerned about is with the very different landscape that we're going to have to navigate even 12 months. If you're looking at the immediate sort of year from a plan perspective, it's going to be very easy to squeeze this out. Very hard when you're trying to nurture and grow what is a relatively new area for us. The ministry resource at the moment. So I think this is a significant risk, and I think we just as a whole got that.
And absolutely like to that. And I think it is new to touch we need to keep. It's absolutely right. And so going back to an action from Carmen, we would like to see this is scheduled out in the way that described already. We need to invite Christine to talk to us about what she's been doing, and that they need to be reported on. I had hoped she'd come in February, but that wouldn't happen. We need to make sure she comes here and then later. And just linked to what we do as a board, we're also linking this with our council owners who are very keen and interested to be our ambassadors at New Kew in this very context. So there's lots of important areas that need to add attention based on you mentioned. So if I may, can I close down? Can I invite colleagues to accept the research and innovation committee report, please? Thank you very much. I'm mindful that Alistair and Peter are with us, so I'm going to suggest we move forward into agenda item 17, which is the clinical leadership model update. I think you're going to introduce this paper, and then our colleagues are going to speak to us about their program. So welcome.
Thank you, Chair. So colleagues will recognise that we're well into the depths of each model, and we have this for a few months. So things that I would still focus on, the things that I want to highlight are, of course, in the lots of work that's going to ensure that this is appropriately structured and the program is progressing in some fashion. Also, we just want to thank Joe Gibson for his inputs and guidance around this. The clinical leadership model I like to say is supposed to bring clinical decision making to our what we do. It needs to integrate up the organisation better, and I think the reason I want to emphasise that is often there's a bit of discussion around can we this in existing in our existing organizational structure. so the integration isn't there. So that's the second thing that needs to achieve for us. And the third thing that needs to achieve for us is maintaining and consolidating our integration into place that we can build on, like to population. Context of this is obviously a difficult financial environment, and again, Kim can talk a little bit more. We feel that with the reshaped organisation, that gives us the tools to unlock efficiencies and more effective doing things. So it's key to us maintaining our sustainability moving forward. It's also one of the key building blocks to harmonising us as an organisation in preparation for things like our digital journey and PR, some of which we will discuss today. I think the flip side of that is we also need to recognise that there is risk inherent in what we have decided to do as an organisation, especially in the context. I think this will be a challenging piece of work to do, even in an environment that wasn't quite as financially challenged and politically charged. So there is risk there, and I think that risk keeps us some apprehension in terms of our discussions. And again, I'm sure there'll be a good discussion around it today, but I think as a board, we need to be very clear on our commitment to our next step and the direction that we have agreed to take. And I'll turn to Claire. I will hand over to them because they will figure about all of those rules. We are in the mission. Over to you, John. Thank you.
Given inducted me into the vagaries of how to operate the system, so apologies if I'm making a mess of it. It feels like quite a long time ago since we last discussed this, so I'm going to take the paper as read, obviously. Hopefully colleagues have found it helpful in synopsis, as a synopsis of where we're at. I'm just going to very briefly touch upon the content of the paper, and then just really looking for the views of colleagues. So I think it's clearly set out how the CLM programme will help us deliver the ambitions that we've got. I think the things that I'd highlight are specifically around financial sustainability and quality and operational performance. So Rafiq's alluded to it already, but the drivers for change that commenced us on this journey are still present. We've referenced numerous times how we need to address things like our governance, our changing leadership, how we recruit leaders. It's all contained with CLM and set out as we've done with the paper. As I've said, those drivers, the transaction, the challenges that we still have as a hangover of the way in which we implemented the transaction, the findings that the CQC had when they visited in 2022, the learning that we've obtained through the Green Report, and what we've seen in staff survey, consistent themes that we need to address. So I think my view is that the drivers are still present and relevant. We've set out the achievements, so hopefully colleagues can see that since we last spoke, a great deal has happened. We're getting to a really interesting part of the programme. Anybody who's been involved in the CDRs recently will attest to the quality of the conversations that we're having, the quality of the products that are coming through from our clinical and operational and allied colleagues, actually what they're telling us. And interestingly, I was doing a medical induction for some new colleagues today, and a colleague who was changing role and moving and attended and reflected to me that, and it's clearly only one person's perspective, but actually said to me, it feels like the organisation's actually listening because what we are saying and what we're seeing through the process are changing. So I think my own view is that it is an imperfect process. You'll never hear me say it's otherwise, but it is delivering the things that we wanted to deliver. So, as I say, great deal of work has been undertaken by the team, Peter, Hazar, Naomi, and actually we're now starting to see some of the detail that I think colleagues will find interesting. As we know, the bits that people find interesting will always be different. So for some, that's organisational structures, and we're seeing a bit of detail, and that's contained in the paper. For others, it's the cultural change, the development of others that will always be of interest. For others, it will be how we interact with our places. The detail that's coming through is absolutely phenomenal. So I think as a process, it's been an incredibly rich and beneficial one for us to go through as an organisation. I think where we are now, we need to recognise the gaps and challenges where we are. So there is there will be, as the designs come through and we start to prepare the work that describes what that journey looks like in much more detail, there will be a programme resource increase required. We will detail that, but I think it would suffice to say that the programme team are maxed out at the moment, supporting the design process, and the work that will take us from here to there needs to be completed as well. So there's a great deal of work that needs to be supported to get us to the place that we're describing with colleagues. I think we also are just mindful that the context within which we're working is changing. So how we interact with the wider system will fundamentally change. But I think one thing is clear, what we've heard through our involvement with system partners, our involvement with our locality leaders who are fully involved in this process, is that they recognise the benefit of this. They see the value of it. Yesterday, one of our place partners asked me to speak to one of our system colleagues around the work that we're doing, because they're interested in what we're doing. And actually, I see, whilst there is a lot of turmoil within the NHS, I think there's a real opportunity for us going through this change at the time that the NHS is changing, because I think it's the right time for us to create our organisational shape. And I think it's just worth acknowledging the risks that we've got if we don't follow through on what we've got. So, we've told colleagues that we are listening to them, and now they're starting to recognise that. So I think we have to commit to that as a process. I think we have to recognise that the problems that we had when we started on this journey aren't yet solved, and we've invested a lot of our belief in solving some of the issues that we've got through this programme. I think there's a way through to solving them, but that involves us delivering on what we said we would deliver. And then just finally, what you can expect from us next. So, and I think it would be fair for me to say that the next step that you will see is likely to be a detailed board paper to describe the outputs of those design teams and the review process that underpins that. We highlight in the document that the timelines for board paper in May were tight. I think if you want my honest opinion today, it was Wednesday. Having done 3 CDRs in the last week, we've made some significant progress. We've made some really substantial decisions, but I think the work that's fallen out of those will mean that I think realistically the earliest that we would have a paper for review is likely to be June. So there is a discussion to be had around what that timeline for submission to board looks like. The second is to hear from colleagues here around what they want to see in that paper as well. So it's a slight deviation from what I've set out, saying that we would go to trust board in May. I'm just escalating that as a result of what happened over the last week in submission, that there's a more significant risk to that programme time.
Just on that point, there isn't a board meeting in June, but
Yeah.
into July. I'm
aware of that, yeah.
I know what you said, but thank you very much. Have you finished?
I have, yeah. Thank you. Peter, I don't know if Peter wants to add anything.
No, I think the only other interesting point is obviously the comment around NHS England structural changes. And I suppose from what I actually went to a King's fund event last week, and they made quite a big emphasis on, and in a positive light, that actually that could mean more autonomy, more responsibility for NHS organisations. So I just think that's a kind of an interesting kind of viewpoint in terms of what we see there.
Yeah, and that's linked to that subsidiarity context. vision to make closer to the service rather than. Thank you very much. I'm going to take questions. Thank you so much for listening to the amount of time to create those reports. It's very clear, tells the journey, and acknowledge both the challenges that you've had and sometimes the course you've taken in order to address some of those challenges along the way. And actually, it was a good indicator that you are listening in that moment. So it's great to hear. Jeff, you have a comment or a question?
Yeah, the piece of it I'd like to see when it comes back to board next time. The around place go so far to say that if colleagues help to see between meetings the design template sufficient for in who that's other rooms just to see details about intending to enhance our relationship with place and on the neighbourhood model.
That's a really important point because that links into how we work in the neighbourhood model and connected relationships. That's not it. Please.
Thanks, Alistair. This is sort of the clearest and most comprehensive view I feel I've had of the clinical leadership model, and I really welcome it. It was a really fantastic read, and really interesting. I wondered a bit about the training piece for managers. I'm not sure how much I felt that was in there. And sitting on People and Education Committee, I know we talked to Julia Marshall about this, and we've talked about training which will be required for this, because I think that's a really important part of this, isn't it?
Yeah. So it's really helpful to hear the feedback and listen to Jeff and you. So the intention is that all the design templates will support. So but what we want that to be is in a digestible format. So to give you an idea, some of the design templates are 60, 70, 80 pages long. So there's going to be a lot of material. What I'm trying to draw out is what colleagues want to see in the overarching document that will help me navigate it. Absolutely, the work that Julia and colleagues have done in that 2A group is amazing. I think they've set out a clear timetable of how an offer is going to be made to colleagues. I think it isn't just about what we do in the immediate future, but actually how we potentially recruit, select people, make that as as inclusive offer as possible, and referencing it back to Breen, how we avoid that sense that perhaps it's, for want of a better term, jobs for the boys, or that actually there's an opportunity available for everybody. So I think it's contained in that. The priority has to be those leaders who are going to occupy new roles in the immediate structure, and that's where the priority is sat. But I think the offer is much wider than that. I don't know, Gertie, if you want to add anything onto that at all.
Yeah, I will if I can have a moment, Chair. So we've already gone out. So the work that, so Nina, Chair of the 2A group, working with Julia and lots of colleagues, and they told us, really importantly, these are the things we want to develop skills in. These are the skills we need, rather than us going, these are the things we think you need to have. Has been worked into the programme. We've already gone out asking for expressions of interest for the first cohort, which will start in April, but it starts in April with sort of 360s and personal assessments and coaching, and then the talk session, so to speak, will start in May and follow through for the year. I think Owen covered it earlier in his briefing, but we've had well over 200 expressions of interest, and I think for us that's really, really positive. Really strong response from our medical and dental colleagues. Great response from allied health professionals, from our operations and corporate functions. We are doing a bit more targeted work around our nursing and midwifery colleagues, and Heather and Juliet are really supporting with that, because the numbers in that space are probably not where we need them to be. But what it's really showing us is a great appetite across the organisation for people to develop their leadership skills. And not everybody will go into this programme, because a huge number of them have not already done the ALDP, and that's again a great starting place for them. But Julia and her team are looking at 3 layers, because some people might be at a very junior level and need to start with the basics of sort of management and leadership, or at a mid-level and move to their ALD or step into this. And what we will see is this is really creating a talent and succession pipeline for us in our leadership field across the organisation. We will run multiple cohorts of this and evolve it as we go through. So I hope that's helpful. But again, if it's not, do please ask me for more.
Tim.
Yeah, I'd echo Aziz's point. This was really good paper, Mr. Swan. I suppose for the next paper, I'd kind of, probably just talking for me here, but what would to do that drill down on a particular service or clinical groups and kind of, I don't know, you could again pick gynae, for example, but actually say this is the unwarranted variation that this is going to unlock. This is our ambition. Our current structures are preventing us hearing from patients and use of our service. This is what this is going to unleash and unlock. This is the time this is going to spare to create, have more face-to-face time with patients. Kind of to give that sense, I think, particularly picking a service like gynecology may have particular headroom for showing that. I think that would kind of not bring it to life, but kind of give a sense of, wow, this is what this could unlock.
Yeah. So we're constantly having the debate around the correct level of detail. You know, when and we're learning as we go. So as the design templates come through, often in that performance section, for want of a better word, where that clinical and operational variation may exist, we're getting a massive data. So there's loads of data out there. I think if we're looking for opportunities for improvement, both in terms of quality of experience for patients and for efficiency, we're not short of examples. So I think that the right thing is going to be to pick the right examples that are going to explain the narrative of exactly what you've said. So having historically had two gynae departments, I can tell you that the way we've reported data historically will be fundamentally different. If we looked at our community services as an example, how we've implemented our electronic patient record in the community, and Lorna would recognise this, has been fundamentally different for the same service on 3 different sites, even though it's the same product. And that's resulted, when you look at the data, not just variation in the outcomes, but even in the variation in the way we report those outcomes. So if we're looking for reasons and examples of how we're going to improve things through this process, I think that it's not going to be a shortage of examples. It's going to be picking the right ones that illustrate the point.
Yeah, and I think that includes us as a board and the committees of the board. I imagine we will need to operate differently. To ignore that would be great loss. So, well, that's for us to do the work on that as well.
Yeah. What I'm hoping is that as we bring the information to you and it starts to become more understandable around the nature of the changes, the way that we want to change, that will help your thinking about how you want to interact with the organisation. Because as the organisation matures, changes, accountability might change and responsibilities will change. Actually, how you want to access that, to connect, to engage with colleagues in those services may change as well. So I'm hoping that that's the sort of conversation that we'll have when it comes back.
Yeah, thanks, Abs.
So if we can make sure.
Thank you, Chair. A few things, but I just want to comment on the gynae example actually, because I actually think this is a really good example of where we can have a better understanding of the improvements that we will achieve with CLM. But mainly because actually we've started doing it in gynae because of some of the challenges that we've had, you know, and the drive that and colleagues have brought. We're well away in terms of structuring that in the way that we would expect post CLM. So it gives you, if you like, a preview of what we would expect of services. So I think that's a really good example. One of the challenges that I think as a board we're going to face now is the reporting is going to ramp up. So the next phase of board papers of what this will look like. And as Alistair has pointed out, the volume of stuff is massive. And actually, one of the discussions we need to have is how we select in a way that gives us the right balance of detail without us drowning in things that we can't quite get our heads around. And I think from Jeff's question, one of the things I will propose is, the design templates and the outputs will be available to any of our colleagues. So I wonder whether we just think through how we make those available so that if particular board members have an interest in focusing on one area, to use, for example, Jeff, the place bit, they can spend maybe some focused time rather than a dump of, in excess of 1,000 pages for us to try and think through. So I'll take that away. Maybe we'll have a little bit of think about how we think that, because we do need a level of need to go slightly high level so that we can get our heads around what this looks like into the future. I also suggest, I hadn't thought of this before, but Tim has triggered this idea. Clearly, there's an aspect of how we as a board will operate after we reshape the organisation, or themselves reshape the organisation. I wonder whether we prioritise this post the paper coming forward for a development session, where we digest what the paper said and just have a slightly more informal back and forth about what we think the future for us and the forward layer looks like in the new reshaped organisation. I want to just briefly refer to the timeline. Alistair and I had a very brief conversation about the concerns in terms of timescales. And this, I think, comes from a good place in terms of the rigor that is being applied to the process. And so there may be a little bit of slippage in terms of board papers. One thing we do need to keep in mind is just downstream impact, because ultimately April 26th needs to be a very hard deadline for us in terms of the full switch with the lead-in a few months before that. So maybe a bit of flex there, or we just need to keep that in mind as we consider essentially what Alistair is identifying as a risk. And the final thing I want to say is, it is in the paper, but I think it's important for us to underline that regardless of what people might think of some of the nuances and detail of the process, we've ended up involving nearly 200 organs in shaping the future of the organisation. I'm sure there'll be a lot of learning that we can take in terms of how we might make that either faster or more efficient, etc. But there is a lot in that actually, and we are starting to hear from colleagues, this acknowledgement that that is something that's different and that they are. So those 200 colleagues now hopefully with ripples to jobs.
Just on the benefits, if I may quickly, of course, but you've been looking at in the design, it's going to see the fit document that supports clearly demonstrate this need to be such detailed information that there's two things, and you should have the full report and have access to that. We definitely need a couple of development workshops going forward, because this transition will take time, and in doing so in a few stages would enable us to pick up on what we need to do now, prioritize what we can do now, and have a long-term plan for implementing some of the learning that's going to emerge and some of the benefits that you will yield from this very perspective.
Yeah, if I might just pick up on Rafeek's point around the timeline. So in some ways, most of the programme timeline can run independent of the trust board decision. We can do the preparatory work, get things in line. I think the greater risk at this point, whatever that milestone is for when we bring the paper back, is the work and the programme resource that's required to get us to a place where we can safely transition. And when we had a discussion recently around safely doing that, and it's clear there's a lot of work that needs to be done to make sure that our governance processes, our people, colleagues are in a position to be able to manage colleagues through that process, etc. So I I don't have any concern or risk around the April 26th as a deadline. But I think the risk would apply if we didn't resource the programme at this point rather than let the programme, if that makes sense.
Okay.
Thank you.
So we, Rachel, please, and then Juliet. Rachel?
Thank you, Chair. 3 swift points. So the first one, we touched on it there at a moment from Tim as well, but really asking the groups that we're consulting to focus on measurable outcomes. So actually, are our colleagues aware of what it is that we see as a board, what measures we are looking at? And, you know, perhaps if they knew that, that would influence some of the input that you're getting from those consultation groups to shape the actual structure to ensure that the outcomes and improvements will then be seen in those measures. So that was something I wanted to bring out. The other one is we've unfortunately had a drop this year in our staff survey in staff feeling that they have a voice that counts. Clearly the timing is off with all these sessions that we're running, but my ask is, you know, the comms plan, are we making sure that we're telling our staff that aren't part of our consultation groups that we are asking and listening, even if they're not personally involved? Can see Gertie nodding, you know, but if they don't know it's happening, it's not happening, you know, if we're not telling them and if it's not right in the face. So hopefully in the next staff survey, we will see the fruits of the labour of all of these consultation. But again, it's just making sure for the next few months before we close that next staff survey that we're doing everything we can to make sure people know the efforts that are going into the consultation. And finally, ensuring the inclusivity of that consultation. You know, we've just had a session earlier where we've looked at the disparity between Black, Asian, minority ethnic groups and the impact across many aspects versus white colleagues. You know, are we ensuring that the people that we're engaging in the groups and the voices that we're listening to are diverse and inclusive, and that they are safe spaces for consultation, and that people are feeling like they can speak openly. Thank you very much, Chair.
Thank you, Rachel.
I'll very briefly respond. So in terms of measurable outcomes, yes, we'll detail those in the board paper, but just so you're aware, as part of all the inputs, the design teams have provided with Vision 10, with the organisational annual plan objective. So there's a clear link to the board alignment there. Absolutely recognise what you say, Rachel, around the staff survey. I think it probably the wrong time. I think what we've done, and it does link to your last point around creating a safe space. So what we've done is we invited, colleagues were invited at the start of the process, but then those colleagues told us that they wanted more other voices involved. And at that point, we opened it out to all clinical colleagues. Now, that doesn't necessarily mean that we've got the broadest representation of all different groups, demographic, but we made that an open offer. It was anybody who wanted to be involved was invited. So, so we made that as inclusive as possible, but we also recognise that that design space isn't always the easiest place to be in. So if you're designing organisational change that might affect people that you work with, we wanted to make sure that colleagues felt protected. And that does, I think, link to your point around the staff survey, because what we've done is not necessarily broadcast the work that's being done in the design teams, because we wanted to protect the design space. We're now entering a phase where we can start to share some of the detail out of those design teams, because their thinking is starting to come to completion. And at which point, I think the narrative is going to very radically change, hopefully. And Julie and I have had detailed discussions about how we're going to change the communication strategy following on from the outputs from the design teams, because then I think when colleagues start to see what their colleagues have been describing and the conversations been having, I think that's when people start to realise the sincerity of the approach that we're undertaking.
Thank you. I mean, we are massively interested in the design, but actually what's most important is that people have been consulted, that they feel it's the best design to lead to those outcomes. So when we in 2, 3, 4 years time are looking at our performance report, we can see a decrease in waiting times, etc. And it's just trying to link back to those really tangible patient measures that we've got as well. But thank you for that update. Thanks.
So Judith, Owen, and we'll end with Chris, please.
Just to make a point on one of the points at the end. Sorry, is it me? All right. It was about the fully developed integrated governance model as part of the single accountability framework. So we've been working together on that. We've had some ideas, but I think just to reassure you that's a build on the work we're doing around QPC as well. So we're taking into account all of what we need to improve now, and then what that will look like in the new model. But we'll also referencing corporate governance and clinical governance within that accountability framework. So it kind of picks on some of the points that people have referred to, but we'll get that in with the next iteration, and then that probably builds on the work you'd want to do for the workshops, because we'll have some clear thinking that will be integrated across all governance.
Yeah, I think it's actually key. Yeah. We need that integrated governance approach. Otherwise, we'll have science here and something would connect to the service for this conference. Thank you very much to Owen, and then Chris.
Okay, I'm just building on a little bit some thoughts on the beginning of the meeting, the Horizon part. It links particularly to a leadership aspect of this. And we have done a reach out, as Gertie's talked about, for expressing an interest, particularly in the leadership development phase. There's some significant things to think about with that. For the medical community, the data set I looked at, we had 210 expressions of interest, which is it's probably not an exact science, but that would be 20% of our body as an example, although I'd be weary of that particular percentage for. But the interesting thing for me is that of that initial 210, and then kind of split into a filter where people are ready now, and a filter that talks about not yet ready but interested. In male-female terms, in terms of ready now, is 59%, 39%, 39% female. I don't know if you should be pleased about that, but I've got a feeling that that's actually encouraging. If we looked at the totality of female represented in the total consultant body, but I'm not precise on that, so that may be a data set that I need to kind of get my head around. But interestingly, in terms of ethnicity, whether it be ready now or not ready yet, they're both in excess of 70%. Which is an interesting thing to think about. Again, I'd be careful about anything about jumping to conclusions of whether that's good or not, because if you think about it in terms of ready now, that's only 22% of white colleagues. So it's a thing to again think about what some of the mean. I think more worrying for me is that when I looked at the data set which I'm quoting from now, the nursing percentage was it's now up to 90, but it wasn't when we looked at this. I mean, you have to do the maths here, but there's more nurses, AHPs, and whatever else than most of what else we do. And if we're talking about the clinical leadership model, and we've had a healthy response from medics to leadership opportunities, I am worried that what's the invite message that people are hearing from our nursing community is one thing, or are they hearing it and thinking, well, that's not for me? And I think we've got to really drill down a little bit in that. And then a couple of other points I'd make is that of the medics that come through, and they all got time for a peak and due to answer this question, Max, something we do offline, is I think there's quite a lot of unusual suspects in there. So I don't think it is a regular cast of people that you would have expected to come forward, which again brings a couple of dynamics into my thought process, which is those people who are currently in clinical leadership spaces. There's a question to me, and I've asked for this work to be done, so I haven't seen it yet. To overlay the people who are currently in leadership positions under our current model, the people who have expressed interest, and I'm trying to see, well, what does that look like as a Venn diagram? My intuition is telling me is that actually there's not a lot of overlap in that. Which again says to me that we might have a bit of a communication message. We might have set decisions to make, because my understanding where we're going on this is if you haven't been through this leadership development, you ain't going to be a leader in the frame that we're talking about. So there's either a lot of people who not understood and internalised that and don't understand they need to be a part of this development, or they have internalised it, do know that they need to be a part of this, but are choosing not to be. So I hope I'm not losing you in this, but there are some things that I think we still need to work through in this space. And I'm not expecting answers now, Alistair, and whatever else. I think I'm talking about some raw data here that I think we need to get on with, but there's some inference that you can take either way on this. And then the other bit I would say is if you look at the just got my numbers right, it's page 7 of 11 of the pack. It's where it's got the sort of level 2 clinical groups as described around that. So the groupings are different. But if I use language of business units and say these were business units, then it's not too dissimilar from what we've got now. Sure. But the fundamental difference, linking this back to £110 million save, and a GMAQ letter that says a 10% reduction in corporate services, the fundamental difference is that, I think, and how that is going to respond to what is articulated on page 7 of 11. Because several things can be true at the same time, but one thing's true is whatever the current model is now, it is not going to be the current model servicing this future CLM. And the quicker we get that articulated and understood and able to describe what is the corporate offer to help service this CLM, I think it's something that it's got to be an expectation of the board the next time that this comes down. So I'm just putting some thoughts, not expecting lots of feedback and whatever in that, but to sow those seeds into how we're approaching this, because there is going to be less resource servicing this going forward, which means you have to get the training and development bit even. You use the word imperfect a little bit earlier, Alistair. I agree. It's imperfect and we will never reach perfection. But we have to get somewhere near it in terms of the readiness of colleagues to take, because that whole infrastructure that's been there, certainly in the current model, is not going to be there in the same way. So we've really got to think that through. So I'm just wanting to there's quite a lot of stuff still sort of up in the air, but in a good way. And finally, because I remember Joe was sat by minutes and we were having a conversation about the degree to which people were involved and embracing this. I'm reasonably confident now I can go out there when we go out from the socket door and we coke a bit later, that there is going to be somebody I bump into who might actually know about CLM. They might not have a positive view, but they will know about it. And I think that's something that we should be encouraged about. Yeah.
Juliet wanted to comment to you,
I think it's on that nursing point, Owen, and I was going to pick it up with Alistair, because I think what's happened with nursing is there it feels like it's contributing to the conversation, but doesn't necessarily feel contributing to the future leadership in the way that it needs to. And I don't know why that is. I think I can see a number of features which would make it a little bit complex. And having myself been in a clinically led organisation, I can see that this is well that clinical leadership, not medical leadership. But I think somewhere in here there has been, I don't think through intent, but I think through perception that some clinical professional colleagues are contributing to going to be leading. So I think there's, and as a result of some of that, we've put some of our nurse directors more closely to the programme. So I think it's a mixture of issues, but it certainly is an issue which we need to address, and we've had the conversation with Gertie as well. But I do think there's a conversation. I think it goes back to Rachel's one about engagement. It's what level of engagement do you think you're involved in, and I don't think it's quite hit where it needed to be, but I don't think it's compromised the place we've got to. So I think the place we've got to still has had enough engagement in it. But
more to be done in the right place.
I think it's more to be done, and I think it's the time to do it has to be now, because this is what we're going to. What does leadership look like, as opposed to what does a clinically led model look like? And I think the clinically led model contribution is working well, but the leadership bit hasn't worked as well as it needs to yet.
Thank you, Julie. Chris, please.
Thanks. Sorry, this will sound very prosaic compared to what I just said, but in terms, answer to the question about what we need to sort of understand, I guess the thing that I can't yet see clearly is actually what the role of the board is, and which bits of this the board needs to be deeply involved in and approving, given that a lot of it, as we've already heard, is already happening. So I just think there's something about being clear. So, for example, in the paper he took about the detailed operational model being presented to the board for approval. The best will in the world, I'd be looking for, asking questions like, well, who's been involved? Has there been the sort of involved? I can't assess the operational model. And on that line, I wondered whether, we can have developmental workshops, all sorts of things, but at the end of the day, that it depends on the process being done through to design something. On that line, I wondered whether there'd been any thought about any external view, assurance or perspective on any of this. I know that's sort of an old chestnut in these situations, but have we thought about that, or do we need to do that? It's very, very internally design driven, and great, because there's been a lot of engagement. Is the that external perspective?
So there's a couple of things. We as part of this, we invited our locality partners in, and they've been a really strong voice and meaningful partner. And being what we've always said in the design process, that is by being in one part of the design process, you have the ability to see every part of the design process. So they're fully inside of what we're doing. In fact, in our clinical design review yesterday, we had one of our locality partners was actually there helping review the document. So we've got some local external voices already. When we set out on the programme, we stated some ambitions around wanting to play this back to both regional, ICB, maybe some provider partners locally, and also the patient voice. So it's a constant theme, which is, what would our communities feel about this? I think it'd be fair to say that the pace at which we've been required to move has meant that some of that hasn't been addressed to date. Sure. But I think if we amend the programme timeline, then there is still opportunity to do some of that, with some of our patient groups, with some of our acute provider partners, to ask them what they think. We're in contact with MFT, who've gone through an organisational change recently, and what's interesting is how many synergies and similarities there are between us as organisations, and actually the materials that they've produced through their organisational change, we're seeing some of those as well. So we're learning from others. There's an opportunity to invite others in to critique and to support us. And the answer is, I think when we set that new timeline out, then if that's a desire from colleagues, I think they'll recognise the benefit of doing that. I think there's still an opportunity to do it. So yes, we'd completely share that.
Thank you.
Well, Chair, with your permission, I was going to just say a couple of things to it. So we leave the last word to Alice and Peter, if that's okay. So I think really helpful contributions and reflections there, which will internalise and incorporate. I think a couple of things worth emphasising. So I think, Owen, your points are really important in terms of organisation structure and what changes, and we don't need to get into detail now. But a couple of things that are worth emphasising. First of all, one of the fundamental differences is for all our services, you will not have multiple versions of the same service. You won't have 2 urology teams. You won't have 2 gynecology teams. You won't have 4 or 5 UC teams, etc. So there'll be one big team with localization as required, depending on the size, etc. And the other fundamental difference in colleagues who sit in the client reviews will be sick of me latching onto this. I think often brings it up as well is there will be one layer less in the organization. Okay. Now, what we do with that and how we operate it, again, that's detail. And colleagues will be pushing us to maintain the same resource. But in fairness to everybody, we've already now started to introduce, given the new context of the NHS, disbanding NHSC financial environment that we're operating in, we are now in the design discussion saying to points, we started off saying this needs to be cost neutral as a starting point. But now we're saying actually we need to be thinking through whether there are any opportunities of saving. So I think that's a really important point. Rachel had a really good point about what we as a board see and look at, and do colleagues know what we're after, which I think absolutely we need to take into account. But I want to make a counterpoint as well, okay, because I actually think that if you look at what we're trying to achieve with the clinical leadership model, it is the mirror image of that. Because I think there's a question to us as a board as to whether or not we are seeing the things that our colleagues think are important. Okay, so in reality, in these future board development sessions, once we have a better understanding, what we need to be trying to achieve is the confluence between those two things that we are here, we need to see, but also us being here and responsive to what colleagues think that it is important. I think that's the fundamental change in terms of work. You can design this in many different ways, and again, colleagues who've been part of the process will know that we've made changes and there have been a multitude of opinions. I want to caution against us using language like the best design. I genuinely don't think there's one best design. The reason I want to not use it is because there will be colleagues out in the organisation who have particular views as to how this should have looked as an output. And we need to be clear that we are trying to balance all the views and all the inputs for something that works for us as an organisation at this stage, because we will inevitably, because we have to make different decisions, have colleagues who will be in disagreement with what it is, and so better versus not better. I think it's in terms of and with that, I just want to thank everybody for the contribution.
And just thank you, really useful discussion. And just to say that the way that I frame this with colleagues is that this is the start of a conversation with colleagues. It's the start of a changing relationship with colleagues. It's not the end of something. There isn't a milestone, a date in which we will reach an end state, and all the great things that we want to do for our patients and our communities. This is a platform upon which we can build upon. So hopefully you can see that we've started that journey. We have to nurture it, like all things that are in their infancy. It's got to be nurtured and looked after. But I think if we do that, we will get the benefit of it in all the things we want to achieve in the future.
Can I thank you and the team on behalf of also Naomi as well. Thank you for the reports, thank you for the progress that we have made, and we look forward to the next iteration. We'll capture the comments and actions that have been discussed and been noted, and we will share them with you. Thank you very much.
Thank you.
Okay, colleagues, we now move back to digital meeting.
Thank you, and I'm very conscious of time, so I will try and be brief. I'm going to take the paper as read, but I'm going to take an opportunity just to do a refresher of where we are. Colleagues will recall that we launched our first ever NCA digital strategy in August last year. And that was very much a foundational strategy about getting the good foundations in place in readiness for change that was coming and in readiness towards an EPR. So it was about really bringing our digital footprint into an MCA frame rather than operating as a Bro and a Salford. We've spent quite a lot of time this last year learning an awful lot about this environment. And I'm very mindful that this report is potentially more towards the reassurance rather than assurance right now. And we need to do some work to actually bring a much more comprehensive way of providing that assurance view that we are making changes and that there is benefit and outcome from that. Crucially, we have an estate that continues to age. So in this last year, we've learned an awful lot more about our digital footprint. We have been doing quite a lot of significant activity to understand our application footprint, and colleagues will remember that I'm a bit like a broken record. We're quoting 380 different clinical applications at you. We are now well over 900 applications identified in this organisation. I can tell you that every week we identify another one. There is a huge benefit to a cost improvement programme. The huge benefit to a digital footprint is that because we have a control on spend, it actually flushes out where you have shadow technology and shadow services, which is why we are finding an application every week. That affords quite a significant opportunity. We are making some financial improvements already. We invested some of our capital last year and work has started now to upgrade the Wi-Fi. When I walked around all of our sites, it is a common feedback in our wards from our porters, from our colleagues in all different areas that the Wi-Fi is just not adequate for them to do their day job. We would put quite a bit of investment in the capital programme. That work has now started to increase the bandwidth across our main acute sites. We've more work to do yet to understand and link and really build a plan for our community teams. And that's to say they are not forgotten. We have over 61 different community locations in our properties. We're working very closely with the estates and facilities team as they build out that estates strategy, because our investment in Wi-Fi in those spaces will need to be directly linked. And we'll also need to work with partner organisations where we are sharing space and they are providing services. So this report hopefully is just a bit of a summary of the progress we are making. There is still a lot to do, and I will continue to say every year that we go by, our estate is aging. There is a real need for us to continue to invest. We really will need to move to a life cycling process that starts to really do a refresh in the same way we would refresh our car and MOT and service it, and at some point it becomes so end of life it's not cost effective to maintain. That really is our estate, and we have a high dependency on really needing to move ourselves to electronic patient record. But we are already working in terms of supporting towards our Vision 10, particularly in our cost improvement schemes with Jude's team on Theatres Excellence, UEC, and other programmes to start to drive rationalisation on the application roadmap now. And we can see opportunities for direct cost savings and productivity improvement by doing some of that early work. So quite a lot going on, but I am hoping to move more to a clarity about an assurance report in future.
Thank you very much. Are there any questions or comments?
Yeah, no, it's just, I guess, to support Lorna in the disruption to our business, the cost to our business of when our digital infrastructure goes down is immense. I have, in my time here, been involved in more business continuity incidents related to infrastructure failing than anything else. So, you know, we absolutely have to pay attention to how we support that. So, and keep the show on the road. Because the cost of not doing it, I don't think we ever go back and add all that up and say, well, what did that incident cost us? Because it's probably too difficult to do that when you work out the amount of clinical and operations and administrative time that it takes in just managing downtime and then reworking all the things that you could do because the digital systems fail.
I think everybody recognises that comments and is also supportive of it. In fact, really informed business case. Are there any further comments or yes.
Yeah, I just wanted to thank Lorna for this. And I know you say it's reassurance, but I found it really helpful to just give me an appreciation of the baseline. 900 one week.
Yeah.
It's one of those things I'm quite thankful that I'm no longer on the digital board. Thank you. But I mean, just the risks and just everything there, what you said there around the fundamentals of Windows being supported in October. These are not things that we can shy away from. So it's get closer to that in terms of how this manifests itself into our things actually.
Thank you for that. Comments. Recognise your point around assurance. So next. Yes, particularly on the legacy system failures that happen to some can do that and start training and implementation. Progressing on schedule, all those things that we have to thank you very much.
Thank you.
Move then to agenda item 15, swine patient safety.
Thank you, Chair. So with permission, I'll just I'll walk through both items that are related and connected, and happy to take questions. So just a few things to draw out. You have two documents in front of you. One of them is the AAA report from the Green recommendations oversight group. This was from an additional meeting. If you recall, last time we discussed the meeting report, an additional meeting ahead of the just to bring some of it together, and then a description of where we are in terms of the action plan and work. From the AAA report, you can see we wanted to emphasize and highlight the alert the bit that despite a lot of on the way, there is still 80% within affected patients and families of the fact that they are not necessarily. Now, I think it's a bit more nuanced, and there is detail in that, and I think we've built some really good bridges and connections, but we cannot shy away from the fact that there is still that need strongly to our patient representatives in discussions, and we are doing things to try and address that. Second thing I want to say is this is a very complex field for multiple strands. There's a green oversight work. There is the action plan that came out of the climate patient safety look-back review with the thing that we're working on here. And there are also additional individuals who have come forward saying that they would like their care review after the publication of first the look-back review and then next. And I think one of the things that has been difficult for us is to maybe agree how best to represent this in a way that gives for the level of detail that requires for assurance, but also in discrete bits that make it not too confusing. And I expect that when I have conversations later with your colleagues, that we still, there's a lot to take in there and take a while for people to get their heads around. I want to just make a couple points of clarification. First of all, there are references to data in both documents of our action plan. So I want to nuance that a little bit because on rereading some of the questions we've had with teams, etc. The language look clumsy actually, so we just want to hear that the data system contract is up for renewal in 2026. there's a process that I think the Heather's and Juliet's team picked up in terms of assessing where we are with that, and that will feed into a process. Just as so just so there's no confusion in there. And the other bit of that I want to emphasise is one of the things that I think helpful in the conversation with candidates. It is easy sometimes to pin some of our improvements or outcomes on a new digital system, and there have been other examples unrelated to final where we sort of say a new system and everything will be fine. So it's just something we're very conscious of, ensuring that we make improvement regardless of the systems that we're using, because we won't always have new systems that fix things. The other thing I want to draw the board's attention to in terms of the AAA report is there was a really good suggestion, I think, from Heather about having somebody independent come in to advise about that interface between us and the patients, because there is a feeling that an element of this is always going to be built on some fundamental mistrust that people who have been through these experiences with us will have. And it may be a little bit optimistic to expect that just through our interactions directly with them, that is going to melt away. So something that is considered and we would like support for. Having said, having described the difficulty with some of the interactions with, involved patients, affected colleagues, families, etc. So I just want to underline that actually that has put us in a unique position to be able to incorporate and disseminate the thoughts and views of these people, uncomfortable as it sometimes been. And that's something I think we are trying best to harness, and there'll be lots of learning from this for us. Now, into the detail of the plan. So, to clarify, colleagues will recall that we discussed last time, and we said that to simplify the reporting and just make it a bit more discreet, everything related to the recommendations that were in the green report will feed into the green recommendations oversight group with the representation, net representation. Jeff is there, execs, patient representatives, and affected colleagues represented. The other bits, which are the action plan that fell out of the smart patient safety look back review, last UPC, we made reference to that and started to include it. And so that can go through QPC. And also, given that the reviews of the patients who have come forward are essentially patient safety issues that are trying to cover whether or not there is potential harm that hasn't been covered, that will go through QPC. So that's how we will report it. At this stage, I think for some points it may feel a little bit, they may feel that they're blind spots, but I'm confident that is mainly because we haven't had, if you like, full reporting cycles with this arrangement. So sometimes you sit in green and sort of think, well, I wonder what's happening in that other bit. Do I have all the information? I think the reverse will be true. But I think as we go through the next reporting cycle of the board and things look clear, the board will have seen the whole spectrum of everything that is there. This is, I think, useful to also note that there is a little bit of overlap. Not much, there is a little bit of overlap between the action plan from Green and the action plan that we see from Smart Patient Safety back review. And namely, what I would point out are the NDTs. You'll find references to harmonizing on both sides, and you'll find references to some of the survey work that's happening within the service. Now, that's a big piece of work, so there are components that sit in Green and sit in Smart Patient Safety back review. So that's where there's a little bit of interconnectivity. The action plan, as we describe it, is our attempt to make it as clear and simple as possible for any external scrutineers to understand where we are. It has evolved, and I would expect it to further evolve because some of the actions are changing as we're doing things. Sometimes we then realize that maybe the outcome that we're getting or we're heading towards isn't quite necessarily capturing everything that that is the essence or spirit of some of the recommendations. So I would expect that to evolve further. So that's something for us to think through. There's always going to be a difficulty in terms of us fully absorbing or fully assessing how embedded some of these changes are. And I immediately jotted down the sustainability document that Jude referenced, because I think we have two issues here. One of them is to have a real understanding whether the interventions that we're making are leading to a wide enough change in the organisation, because I think all of us would agree that you have spinal as the core issue. Some of the issues that we have discussed and described, you would absolutely see organisation culture that will have impact on services as well. So I think one of our challenges, we don't necessarily have a full answer for yet, but we are very conscious of, is what does this mean in terms of the change we're actually making wider in the organisation, and we need confidence that we're touching too. But the other bit is essentially what we discussed earlier in maternity. Once we have come to the end of these actions, when we close on the bottom, question marks, and how can we be assured as a board that actually there is that sustained improvement? That's something we need to think about. The other thing I want to mention, because some colleagues have sort of emailed saying it would be useful to understand this or that. One of them is there is a survey that came to the Green Oversight Group this was done by the representatives of the affected colleagues, and you will know that we have a course of affected colleagues who self-identify and are referenced in the Green Report as the Green Study. So this survey was done by one of the colleagues who sits on the group, and it is the result of a survey of a subset of those colleagues. Can't remember the exact number, but I think the total of the whole group is 30 colleagues. This is a subset of 10 colleagues within the spinal surgery service. And a lot of the stuff that's come back in these questions is expressing significant dissatisfaction with where we are as an organisation. So something we need to think in terms of management, both in terms of contextualizing it in the wider scale of and understanding there are specifics to that particular group, but also ensuring that we have absorbed all of this. And so what we've done is we've put that into the action plan from the sort of cultural side of things. And I reached out to the survey to essentially test and say, would it be useful for us to have a meeting that includes myself, potentially Heather and some experienced colleagues, to again get into some of the detail of that. So it's not something that we're ignoring at all. We just want to ensure that we're approaching it in the most constructive way possible. And with that, I'm sorry, I have to move on to it. We're very happy to get into specifics.
Thank you for both the updates and someone go to the questions and comments.
Yeah, first of all, very grateful to Rafiq for that explanation. Very helpful. My only other suggestion would be that in the report on the recommendations, there are a number of places where we list additional things we now need to do. I would suggest that we need some timelines to those things so that we can get to a point where we are at a pace to be able to say these recommendations have or haven't.
But so I think that's absolutely a valid point. Two things to clarify for board. This paper is for board sort of digestion, so to speak, and mirrors sort of multiple action plans that will be moved together so we have an understanding. So those will be there, and we'll make sure that we vast majority of the actions aiming for them to either be closed or have very, very clear time trajectory by the end of April. So that's the aim, and we will report on that in the next iteration of this, which we expect to bring after our next Green Oversight.
And within that, can we have an update on patient engagement and patient voice?
Absolutely. So one of the things, obviously they're present, but you'd see in the paper that we recognise that there continues to be a gap. And we agreed that we will go to meet with the wider patient group, because normally we meet small. In May, I forget the date now, but by the time we're looking again, we'll have had that meeting, and if you like, there will have been another cycle listening and trying to understand the issue.
I'll be with you at that meeting. So, thank you very much. The board colleague, can we accept the report from the Green Oversight Group? And also, oh, sorry, please. No, no.
Sorry. Always one. Please, just, the report's really helpful. Is this intended for, I mean, clearly is in public?
Yes.
Public discussion. Is this going to be the subject of discussion with the relatives? So I just wondered if that's the case, whether it's just worth looking at the wording of some of the actions. Just if I was a relative, we might understand what's been put out. I'm not sure they'd always be fully clear to a relative. So just a thought that if it's going beyond here, that maybe it's just a few things to look at. There's a few times when they're expressed in sort of what you might call NHS shorthand, and it just might be worth looking at on the basis of helping to clarify that, that discussion, transparency.
So very, very good point. And actually, we're aware of that. Part of the reason for this, and I think it's worth saying that we have a very engaged group of patients and family members and representatives who we know will be work papers and reading conferences, etc. So they will see this unfiltered version. Very aware of that, and we will make an effort to ensure that we convey in ways that are understandable and disambiguate anything that's an issue. Part of the reason this is the case in this report is that we wanted, because of all our discussions, to be these are the actual actions from the individual action plans as it is in terms of the articulation. But we will go back and maybe finesse some of the wording. So very, not make excuses at all. So take the points absolutely on board and we'll work on it.
Keep the point that you made to put that data.
Yeah.
So again, can I move to?
Okay, just to say I have a call tomorrow actually with Angela Connor, who leads the patient, she chairs to discuss that about how do we communicate this.
Yeah.
And she's got a copy of it, but you haven't done it.
Just
yeah.
Give it some procedures.
Any further points? You can't come in to accept those reports, please. Thank you. Change portfolio to 2016-1. Let's review on.
Thank you, Chair. I'll quickly do our bit again on the assumption of reports reg. Just to say that in terms of the alert, we've got a similar thing to when we discussed this last time, that there are some of our programs, particularly those programs that tend to be cross-cutting, so it blends into a lot of what we discussed today, where we've perhaps got further to do in terms of getting the right level of program assurance, and it can be for reasons like financial benefit it's not realised, or for example, software work clarity around extended scope and so on and so forth. So again, things for us to work through around that. Just in terms of matters to advise, and again, we talked a little bit about some of this in terms of the notes that I did in terms of price scanning, but we did quite a useful session around 3-hour session, which we kind of do that we'll be made through the reality are, and we've done the kind of result now. We now need to do the big bonds, but quite rich in its analysis of what it's like being an SRO in this particular world. And some people say, well, I never volunteered to be an SRO. Here we are. So again, and obviously, several non-executive soon who actually joined the K portfolio board, who replayed some of that back at a point in time around some of that. And again, we touched on the digital FFP, closure on the target operating model, and there were kind of 9 recommendations for learning around that. We absolutely feed into what we're now going to be doing for the year around some of that. And then again, we move on to the general overall assurance on the 30 programs and so on and so forth. again, we also again, and I think one of the things that I would really say is the blend of the change portfolio, but also a blend of our cost improvement planning discussion, particularly in relation to risk, and a real sense now that given what we've got ahead of us, that our approach to risk is not just really about identification and whatever else. We are going to be carrying known risks now that require ongoing risk management as opposed to articulation of the risk. And for several people, that is going to be a different skill set in terms of you kind of know that you're carrying risk and therefore you need to purposefully manage it. But that's been part of our conversation with the change portfolio. And there's more developmental work for us to do in terms of what that means when you are actively managing the risk as opposed to describing it or logging it. So there's more that we'll talk around that. And then just in terms of approval, yeah, we approve the on the target operating and also the amended board should stop red check and the police will be as well. But if there's any questions about that to come.
Are there any questions to come?
So I'll do the portfolio assurance report the usual horizon 16.2. Just in terms of the format of the report, just one thing to reference. So the programmes that are in scope of Change Portfolio Board, their contribution to the financial sustainability plan. That's those identified as green boxes on the scope slide on slide 6 and 43 in the report. The assurance in particular around delivery of benefits is focused primarily on the 24-25 financial year in this report. The individual assurance statements for those FFP programmes include an extra assurance dot this month, and that's to show the progress with the FFP benefit definition of now stepped into this current financial year 25-26. And that was very much aligned with the cost improvement programme reporting at the date of the report, and it's only applicable for this month. So from the April assurance review, the main assurance ratings were based on programmes of work for the 25-26 financial year. In terms of the assurance at a portfolio level, so again, slide 11 of 43 shows the graphs showing the trend of the overall government delivery assurance ratings. The total number of programmes in the portfolio this month was 16, 13 of which are being assured. However, that does include the corporate target operating model programme, which, though in reference, was approved for closure in March as Change Portfolio Board. And that was following Gateway 3, which is effectively the programme closure evaluation. So as a result, that won't be subject to monthly assurance from April onwards, so it'll no longer appear on the dashboard from April, with the Gateway 4, which is our post-implementation review, being carried out in about 6 months to 6 months post-programme closure. In terms of the assurance ratings themselves, there was no movement in the overall assurance ratings in March. And we can see that on both slide 11 and 12. I won't go through which are green and which are red this month. We've seen that on the dashboard on slide 12. And as usual, any programmes with any red or 5 ratings were highlighted in that notice to alert section of the AAA report to direct attention to anything that might need scrutiny. So to allow any discussion.
Thank you very much. Are there any points of clarification, comments, questions about it?
It's not a question, it's more a recognition. We're working very closely with Louise and her team at the moment about at what point we step into the portfolio assurance for the electronic patient record programme. So a lot of our focus right now, colleagues to be aware, is about shaping the outline business case. And we have started really focusing on electronic document management system. So we do have activity happening in that, although it's still, lowercase activity, but we are working closely with Louise to make sure that we have an appropriate point at which we bring that governance and assurance piece so that we can provide that level of assurance.
Thank you. Any comments? Yeah.
Yeah, thanks, Chair. Just to build on one point that Louise has mentioned there, she mentioned that the corporate TOM is going through a gateway 3, which is the programme closure. But you also alluded to a gateway 4, which is the post-implementation review, which I think is relevant in the context of the discussion you had earlier about maternity. So the programme management framework and assurance framework includes a gateway, which is not necessarily 6 months, but it could be 6, 12 months post the programme completing to check that benefits are sustainable. And actually more than that, to check that there is a framework going forward to make sure the benefits don't disappear. So it is part of the framework of the NCA management of change programmes. Thanks.
Involving more people, really presentation. So thank you very much. Dear colleagues, how we move then to agenda item 17 and 8. So, yeah, the 17 we've done, 18 and 19 off on noting. With information. Agenda item number 20 is only business. Or reflection. Fasting is actually very good for you. Okay, we're well over lunch. All right. Date and time of next meeting, Wednesday the 7th of May at 9:30.
So I've got one reflection, if I may.
Okay.
It links back to
eat.
No, I'll be quick. Clinical leadership model. So I've been here 2.5 years, and this is an 18,000 employee organisation with many, many different services. One of the things that I think is important to us as the board and as board members is that however long some of the documents are for CLM, what I've learned is by reading those, I've got a much better understanding of the services and the functions that we have and the scale. So there are detail in the CLM documents, the design documents that talk about how many wards we have, how many members, how many nurses we have, how many consultants we have, and describing quite a level of detail to somebody who's non-clinical, who's trying to learn this organisation, actually what we have. Now, I can't get that from our intranet. I can't get that from walking around. I can try, but actually I think there's something incumbent on us as a board that we should find the time to read those, because that is telling us about our organisation, and it probably will drive us to want to look at different metrics going forwards. It will drive what role we play in clinical leadership model when we come out the back of it. But it's a real opportunity to learn. I've learned so much. I found it challenging, but actually I think we need to find the time to do that. I just want to reflect on that.
So a bit of reflection. Sure. The date of next meeting is, as I said, resolution to close the board meeting. Thank you, colleagues online, you've been very patient. Oh, still doing meeting closed. Oh, it's been 2:20.